चाय। Good morning, Doctor. Good morning, Dr. Anil Awad.
Can we start?
आदित्य, मेरा वीडियो चालू कर।
Doctor.
ये मेरा वीडियो बंद किया है।
Ma'am, you can start your video actually, but I have sent you a request.
Start. Dr. Awad.
Anil, can I start? Dr. Award. Dr. Award, can we start? Unmute. Dr. Award, you unmute yourself.
I think he's on the call, so let's wait for a minute till he gets back.
Good morning.
Good morning, good morning,
Yeah, Jitu bhai.
good morning. मेरा आवाज गया है
किसका?
मेरा
क्यों बिल्ली अभी बीवी के ऊपर चिल्लाते हो क्या?
It's online. It's online.
नो प्रॉब्लम, चलता है. घर घर की कहानी है.
Yeah, Dr. Limay is just joining, I told her. और क्या खबर है? All well?
We missed you on that day.
Yeah.
चलता है, some other time.
So Aditya is there from Depreciate.
Yes, sir.
Girish Lad,
बोलो.
you have to tell all the people they have to join and remain online for at least 1.5 hours. Otherwise, they will not get points.
Not why 1.5 hours. Totally.
People have to be there.
Yes, it is not touch and go system.
Yeah, we are checking the records. People are
Yes,
joining
yes.
and getting out. They will not get points. Good
Good
morning.
morning.
Good morning, everyone. You have passed on the message, Dr. Jitesh.
Yes,
Already.
it is very important. Keep on repeating the message.
Yes, yes.
I can't talk much, bad throat.
This is like Dr. Anil Awad, आपका नाम क्या है? It is like that. बोल दिया already. You know, there was a nice scene in movie. Om Prakash asked, क्या मैं अंदर आ सकता हूँ? चलो मैं तो आ ही गया. You know, it is like that. Jitesh has already
Hey,
conveyed.
Dr. Lad, what happens, like these people don't understand. We send a Zoom list to MMC.
Yes.
Council, and sometimes they have a random check, and then they find out that these people are not attended. Maybe someone has attended 10 minutes, 15 minutes, and then they have a complaint.
Then that cannot be approved.
Yes.
Yes.
So unless you attend the whole webinar.
Yeah, another thing I would like to tell them that I will say when we start the webinar, that there is no need at all. Rather, it is a nuisance for people who are observing the webinar that everyone writes, this is Dr. ABC.
They should know.
Yes, yes.
Registration number so and so, contact number so and so. It is not required because it is not acknowledged at
Yes,
all.
yes, yes.
डॉक्टर
Rather
और वो एसपी रेमा
unnecessarily
वाला का बताएंगे?
they are wasting their time.
Yes,
At
yes,
the same time, they are creating a nuisance in the screen. When people are observing something, suddenly the news flashes saying that I am so and so, mobile number so and so, and registration number is so and so. It is not required because already registered with DigiShield when you register for the webinar, and it is your email is also registered. See the same thing.
Yes, right. And another thing is that they should log in with their own name. Many times they log in with their son's, daughter's mobile, and sometimes with their only the name model of the mobile comes on the screen. So again, we have to find out who was this person. So I think it is better they log in with their own name.
They will be not given points.
Yeah. Yes. Yes. Dr. Lad, I think we can start.
Yes, we can start.
Yeah.
Okay. See, good morning, everybody. I, on behalf of Indian Medical Association Mumbai branch, welcome you all for this webinar on the occasion of World Asthma Day. World Asthma Day, we have already celebrated live in Dharavi by having informative session as well as interactive session under the chairmanship of Dr. Anil Pachnekar, the king of Dharavi, who had got a big name because of his extremely big work during the COVID times, so-called Dharavi pattern. That day we gave informative lectures in the evening, and there was an interactive session as well, and it was supported by a pharmaceutical which is into the medicines for asthma. Now we know that the basic understanding of a disease, the very fact it is called disease means you are not at ease, and that is called a disease. So asthma is a peculiar entity where you are definitely not at ease. You are not in a position to breathe. More important is than breathing in, it is very difficult to breathe out. And that is the reason asthma is, there are various types of asthma. Like for example, you have a bronchial asthma, then asthmatic bronchitis, simulating asthma, then we have cardiac asthma. So there are various reasons to have that kind of presentation. So it is always better, don't do self-medication, always better to approach a physician or a chest physician and get it settled, get it diagnosed, and get the treatment done. Because it is, although it may not be a totally permanently curable disease, but it is a disease which can be controlled to a great extent. The live example is our great Amitabh Bachchan, that he is also a patient of asthma, but still he could tide over, and we always seen the activity that he undergoes, and exhibits in the films. So therefore, it is better that you have properly diagnosed asthma and get it treated. With this, I hand over to our president, Dr. Anil Awad, for his presidential address.
Yeah. Thank you, Dr. Girish Lad, and welcome to this webinar on World Asthma Day. Friends, I think Dr. Girish Lad has already told you about the celebration we had on the World Asthma Day. We are a little late on this webinar, but we were looking for the Sunday, and that's why we are today meeting on this day. As Dr. Girish Lad said, asthma is the biggest problem for Indian population. We say that at least, 1 in every 10 patients of asthma are in India. So this is a very high prevalence. We have almost 30 million patients of asthma in India, and majority of the population is pediatric. So we have to take care of this asthma, which is preventable. And we will be having Dr. Anil Pashnikar, who is the chairman of the World Asthma Day, maybe in between, and he will talk about the things more in detail. I just want to share one more thing is that we had a visit of our national president, Indian Medical Association from Delhi, Dr. Sajanand Prasad Singh, last week. We were really proud to have him in our branch, and we discussed many issues pertaining to doctors. In that meeting, we had a one-to-one meeting with other branches also. We discussed about CPA, CEA, mixopathy, violence on doctors, and many such issues in detail. And he has agreed to look into all these matters, and soon we will have some fruitful results of these discussions. Another thing is about vasectomy center. I keep on telling you about this center. Our vasectomy center is in full action. We have done almost 13 vasectomies in a month, and I'll be looking forward for at least 25 vasectomy in a month in near future. Friends, those who want to refer the patient for vasectomy, they are always welcome. The patient who gets vasectomy done on him will be getting rupees 10,000, and the motivator will be getting rupees 3,000 as a motivational charge. So be fast in sending the patient, because really our vasectomy center, like last this Friday we did 3 vasectomy. Again 3 vasectomies are there on coming Monday. So we are in full swing. So I request you to send the patients to our vasectomy center. With that, I'll just stop here. I request Dr. Kajal Ahuja, Assistant Director of IMA CGP Mumbai Sub-Faculty, to start the programs. I think we have the speakers with us.
Dr. Sevanti
has not joined as it seems.
She's joining in 2 minutes.
Okay.
So I'll wait or I'll start.
You
Don't
talk about
read her biodata. Don't read her CV till she joins.
Hello.
You can talk about the vasectomy center.
Yes. No. I have already told them about vasectomy center, and it's like it has been approved. Another most important thing I forgot to tell you that our vasectomy center has been approved by MCGM, and now we are getting patients from the ward offices also, different wards of Mumbai also. So because we got the approval, because it is really a state-of-art vasectomy center, we have got all latest things with us, and even the surgeons who are doing vasectomy are renowned people, senior people who have worked in this field for many years, and they are doing the vasectomy. It's just maybe a 15 minutes procedure, but it is done in the expert hands. So nothing to worry for the patients also, and they can easily come. And patient need not stay for a long time also. Like we discharge the patient within 2 hours. It's done under local anesthesia. So it's very simple procedure. So you can just direct your patients. Yes, Dr. Jitesh?
Next webinar.
Yeah, yes. We have a next webinar coming up on 29th of this month, 20th May, and we have on 31st May we have a World No Tobacco Day. We'll be having a street plays on that particular day, and the webinar is just 3 days prior to the day. It is again on the No World Tobacco Day. We'll have lectures again on oncology and few lectures on oral cancers and the ill effects of tobacco and the tobacco related products. But we will mainly the webinar will be on oncology. We have already confirmed some 6 lectures. If we can get 2 more, then we may give you 2 points, and otherwise it will be a 1 point. Friends, do join in large number, because since the COVID is on a lower side, we may start with doing physical same is. So webinar is something where, you can really be at home and earn points. So whatever webinars are coming up, maybe we'll have webinars. We are starting with the physical same is on 12th of June. We are getting many phone calls from people that we want physical same is. And I'm happy to announce that we are starting physical CMEs. First physical CME will be on 12th of June. So do register and do come and attend the CME in IMA hall with a lunch, of course. And we'll have another physical CME maybe on 26th of June. So these are future programs which are coming up. And I request
on 28th.
12th and 26th. 26.
Allergic rhine.
And might be one or two webinars. Yeah, one more thing I forgot. We have another webinar coming up on this 28th of this Thursday, no?
Yeah.
2020.
2020.
It's in the afternoon. It is on allergy and asthma again. So it's a part of this program only. And we have 3 lectures by eminent doctors. One is Dr. Harish Chafle, second is Dr. Ahuja, and third is Dr. Mitul Bhatt. He is an ENT person. So they'll be talking on allergy and asthma. It's a 2-hour webinar in the afternoon from 3 p.m. to 5 p.m. with 1 MMC credit point. So again, I request all of you to join for this webinar in the afternoon. So this is all about update on the forthcoming events. Dr. Limia has not joined as it. Dr. Jitesh?
Yeah.
Can you follow up?
I think there was some misunderstanding. She thought it is 10:15.
Okay. Then we could have joined with the second speaker. Yeah, she joined.
Yes, she
joined.
Good morning, madam.
Good morning.
Very good morning, Dr. Limay.
We're just waiting for you.
Time for 10:15, but
Yeah.
ready.
There must be some miscommunication. Yeah.
Right, sir.
No, that is okay.
Thank you very much for joining so fast.
Absolutely. You want me to start? Wait.
Yes.
1 minute. Yeah, first introduction.
Okay. Dr. Sevanthi Limay is a Director Medical Oncology, Director Precision Oncology, and Director Clinical and Translational Oncology Research at Sir H.N. Reliance Hospital and Research Center, Mumbai. She received her medical degree with honors from Jawaharlal Nehru Medical College, Bhagalpur, and did her residency in internal medicine from New York University, and did her fellowship in hematology and medical oncology from Albert Einstein University, New York. She also did a master's in patient-oriented research, cancer genomics and biostatistics from Mailman School of Public Health, Columbia University. She has been involved in research with leaders at Memorial Sloan Kettering Cancer Center, Dana-Farber Cancer Institute, Columbia University Medical Center, and National Cancer Institute, USA. She serves on Tata Memorial Hospital Ethics Board. She has led several national and international trials and has been a part of data safety monitoring boards. She was awarded with the John Flynn Young Investigator Award for Excellence in Clinical Research, the Rose and Jack Horwitz Award for Excellence in Patient Care, and Medical Oncology Research Excellence Award, ESCO 2008, for Excellence in Clinical Research. She was nominated to serve as the National Chair of the Sub-Protocol Arm B of the landmark NIC MATCH trial. Today, she'll be talking to us on the role of targeted therapy for treatment of NSCLC. Over to Dr. Sevanthi Limay.
Thank you, madam. And thank you, sir, for having me, Dr. Anil, sir, and Dr. Mehta, and the entire IMA team.
Yeah.
I'm unable to share my screen. Now
Yeah.
I can. So thank you for that kind introduction, ma'am. And I would just like to elaborate on one single point, and that'll help you understand where I'm coming from. So as a junior faculty at Dana-Farber Cancer Center, I was exposed in the year 2008, 2009. I was exposed to the revolution of cancer genomics that was happening. What do I mean by that? I mean that it is around early 2000s that a very big change, a revolution in cancer care came about, wherein pathways in cancer treatments were described. One such first message came out of EGFR positive lung cancer. That was one of the first pathways that was discovered, described, and treated after a decade of break of when CML was recognized and Philadelphia chromosome was targeted. Post that, there was a lull, and it was only in 2006, 2007, 2008 that we understood that lung cancer, which was synonymous with death and dying, there was a change in practice of lung cancer that was brought about by discovery of EGFR, which was an EGFR mutation, which then led to EGFR mutation-directed targeting and changed the face of management of lung cancer. Right around this time, I joined as a junior faculty in Harvard Med School, Harvard University at Dana-Farber Cancer Center. And one became privy to a lot of this kind of testing, treatment, and you had to learn on the job. You had to come up to speed to understand what was cancer genomics, what were the tests that were being done, and how to target lung cancer. Slowly and steadily, this field evolved, and all young patients who were diagnosed with ALK positive lung cancer, ROS1 positive lung cancer, were being defined and treated. And I was an early drug development or a phase 1 clinician alongside being head and neck and lung. And you saw the very early developments of these pathways and treatments of these pathways, which was transformative. I'm going to show in my talk how it was patients who were, young patient, 28-year-old, heavily pre-treated, multiple lines of chemotherapy failure, disease everywhere in the brain, bones, lung, liver, everywhere. And then you do a genomic analysis, a testing with which you find out that this person is ALK positive. And you then give them ALK inhibitors, a pill, and you transform the disease. And within weeks of starting treatment, the disease just disappears. And when you see these kind of treatments happen, it's transformative. It changes your mindset. It's revolutionary. It just transforms you as a person, as a treating clinician. And that's exactly what one witnessed in the early 2000s. Fast forward to my shifting to Columbia University, where again, much of this exposure, and then nominated to serve and write the Arm B of NCI match protocol. So NCI match protocol was a very ambitious precision protocol, wherein it was a 40-arm national level study open at 4,000 centers in the US. It was funded by National Cancer Institute in the US. And it was a national level appointment. And so it was a huge honor to serve as a PI and write one of the protocols of NCI math study. And that still remains one of the most ambitious precision oncology studies in the world. And having touched by these two scenarios, I think one was just programmed in a way where you approach the patient with that intent. And hence the segue for this talk is very well set. It is a topic, a subject very close to my heart, not just the fact that I identify myself as a lung cancer doc, but also the fact that it is lung cancer is the poster child of precision, because that's where all the messages in precision came from, all the pathways that were transformative, all the pathways that were revolutionary to designing cancer care in the new way, in the novel way, with multiple pathways and targets and biomarkers, which are inherent and imperative to the treatment of cancer today. So with that, I begin a quick talk with a curtain raiser, and I understand that the time is tight. So I'll just take you through some of my nuances and understandings of targeted therapy in lung cancer and where we have come now. So you must have heard this talk many, many times, and I'm sure this is just a revision, and I'm preaching to the choir. But this is very close to my heart. So I will take you through the story from my eyes and my approach. So lung cancer has evolved, and you have adenocarcinoma lung with so many pathways, and you have squamous now being discovered to have so many pathways. We have all these applications mainly in late stage, and now a lot of these applications are also being moved to early stages to get better results, to treat with better outcomes, and also with less impact on quality of life. So in the near future, even stage 3s and stage 2s will have application of pathway-directed therapy. We are already seeing that in EGFR positive lung cancer, and we'll see that in other pathways as well as the trials mature. Having said that, for now, this slide is mainly for advanced stages. So non-small cell lung cancer, earlier until much recently, we had it as adenocarcinoma, squamous cell cancer, large cell cancer. But now you have molecular pathways defining which type of adenocarcinoma are we dealing with. Matching the targets with the therapy is the cornerstone of how we manage the diseases now. So it is very critical that if I have an Asian female non-smoker, I think of driver mutation positive lung cancer. And with that, you slot the patient in one particular slot. And you then go after being a detective in trying to figure out what is the driver mutation, because that's what you need to treat. And there are pills and drugs that are for each one of these. And you can see some of the listing here, where you target the pathway and you don't treat with one size fits all approach. So as soon as a patient walks in, my first job is to assess the patient. If the patient is calm, not in a panic, not in a clinical crisis, then I would do the testing, because the testing turnaround time is almost 1 week. So the patient has to be able to be stable for 1 week for me to figure out through the testing and then give them a pill. If there is a clinical crisis, then I would start the testing. In parallel, I would give the patient 1 cycle of chemotherapy while waiting the test results to stabilize the patient. And then as soon as the test results are back, I would switch the patient to the targeted therapy. But there are so many targets to look out for, to watch out for, and to target as soon as you get a patient that you know is a non-smoker. Typically, the prototype is an Asian female non-smoker, but in India, I also slot it as Asian male non-smoker. So as long as we are certain that the person is a non-smoker, the detective job starts right there. And you really need to look till you find it, because driver mutation positive lung cancer is best treated through the driver, through the pathway, with a targeted therapy drug, and not empirically with chemotherapy, and definitely not with immunotherapy. So if you're thinking of a protoplasm, of a prototype, of a clinical prototype of driver mutation positive lung cancer, you do not give immunotherapy to this patient. That is the writing on the wall. It is now, the field has evolved. It is now considered a medical malpractice if we give to a driver mutation positive patient, you give immunotherapy, because these patients don't respond to immunotherapy. Actually, it will do them harm. So targeted therapy has modified natural history of lung cancer. You have patients living for years together with the targeted therapy. treatment that could actually be oral, preserve their quality of life, and give them better outcomes than the routine. We have multiple consortiums actually showing through these survival curves that if the patient receives the targeted therapy, their outcomes are better in the Kaplan-Meier curve, where you can fit in two rulers in between the survival curves, is speaking its own story to tell us that targeted therapy is the name of the game, where you have patients coming in with stage 4 lung cancer. And on average, you're able to give them a 3.5 years of median survival with the help of targeted therapy drugs. And mind you, this is a bell curve. So you will have patients who will live many more years, more than 3.5 years. And there are, of course, outliers that would live for lesser time when they have something called resistance to pathway-directed treatment. And that's when survival can get limited if they develop resistance early. And I'm going to outline that as well. So when a patient comes to me, at least these 5 biomarkers need to be tested at doorstep because we have treatments. What do? I actually do next generation sequencing, a broad molecular profiling, because the tissue is usually tiny. In lung cancer, you have dearth of tissue. You had a CT guided biopsy or an EBUS guided biopsy. You have tissue which is small. You need to do your tests at one go. Why is that so? Because if a patient is EGFR positive and concomitantly speaking, the patient is also positive for a gene mutation called P53 mutation, which is a tumor suppressor gene. The concomitant presence of P53 mutation with an EGFR is actually warning you that a pathway of resistance may develop sooner than what is predicted on the treatment paradigm. And that is where I believe that understanding right at the outset what is the genomic layout of that patient is very critical. And I would rather utilize the tissue to do the testing sooner and do it comprehensively in one go. And there are many, many Indian labs that are doing excellent testing today. They can they provide it at a cost-effective rates instead of doing single gene and paying 10,000 for each gene and costing 50,000 for these 5 biomarker testing. I would rather do a 400 gene panel for 50,000 rupees. So that's how you rationalize. That's how you work through the logistics and feasibility of testing. One of the new kids on the blocks is BRAF, because we have BRAF inhibitors in the country, and we need to recognize these pathways to be able to treat them better. So we know that EGFR-directed therapy actually enhances survival for EGFR positive lung cancer patients. We have updated survival results open for stage 4 cancers. But now we have a DURA study, which is with EGFR-directed therapy for stage 3 lung cancer patients, stage 2 lung cancer patients who are actually EGFR positive. If a stage 2 lung cancer patient undergoes preliminary treatment and is EGFR positive, there is data today to put them on EGFR-directed therapy maintenance treatment for a period of 2 years post primary definitive treatment. After you've given chemotherapy, you put them on maintenance osimertinib, and there is significant advantage for progression-free survival that is now being proven, shown, established. And the distances between the Kaplan-Meier curves are so large, and that just justifies the recurrences being delayed, that it is today's standard of care to offer EGFR-directed therapy even in adjuvant setting. We recognize today many different variants of EGFR. So it is now time to understand the nuances. It's not just EGFR that is important enough. We have to understand which type of EGFR, and in the type, which variant of EGFR, and accordingly, we can treat the patients differently. So here is a case where you have adenocarcinoma of lung initially, and you have a patient on EGFR-directed therapy with significant response and develop resistance also to response. And when you have developed resistance, you can figure out the methodology of resistance and you can treat the patient with a nuanced way of therapy so that then the resistance is overcome. You have exon 20 insertions, which were not described earlier and can be treated with different EGFR inhibitors, need to be treated with novel drugs, which is a drug called Amivantamab, which can treat these patients better. You have the drug available on compassionate basis for this particular patient, because this patient was an exon 20 insertion for EGFR. This patient was treated differently with a drug called TDM1 pertuzumab, or you could have even treated this patient with a combination chemotherapy and targeted therapy, which is now nuanced to understand whether the exon 20 insertion is in EGFR or HER2, and how do you do the treatment differently. If for an HER2 exon 20 insertion, it would be drugs that are in the HER2 pathway. For EGFR exon 20 insertion, would be drugs that are in the EGFR pathway. Amivantamab is a drug that is like an original drug called cetuximab. It targets the EGFR receptor in the extracellular domain, and it is able to shut the downstream signaling of this pathway to then cause disease cessation and disease control. We have many, many drugs coming into the EGFR pathway, and now you can see so many different combinations that have been utilized to address this EGFR exon 20 per se. So the field has evolved, not just in terms of what treatment you utilize for EGFR inhibition, but also for the nuances of EGFR, so much so that you have so many variants today. And as per the variant, the treatment may change. The database has all these details wherein you can focus with specific drugs, you can focus on specific variants, and several one of these drugs are actually available in the country, wherein you have to understand which drug to ask for this patient and which combination could be effective for that patient. One of my recent patients actually responded to Amivantamab and osimertinib when only Amivantamab was recommended by international faculty. By adding osimertinib to this, I was inhibiting not just the extracellular domain of EGFR receptor, but also the intracellular domain of the EGFR receptor. And I based my treatment strategy on this paper where they had treated with osimertinib and cetuximab way back in 2019, targeting both sides of the receptor. So one has to really go out of the box and think things through. And similarly, if you have a HER2 exon 20 insertion, you actually treat with HER2-directed therapy. So this is a profiling that is telling me that the patient is exon 20 of HER2. And in this particular patient, a new drug was utilized called punitinib, and the patient had significant response to treatment. Moving over to ALK rearrangements in non-small cell lung cancer. ALK again has developed over a period of time, and I was first-hand witness of ALK pathway and ALK pathway inhibition in the US, because if you see, the first ever studies came in 2011, 2009 is when I was already witnessing the phase 1 of these studies in Dana-Farber Cancer Center, where I was in the early drug development unit. And as you see from here to 2022, we have multitudinal drugs lined up that can actually help direct ALK inhibition therapy. And alectinib is one such drug which can be very well tolerated. It is oral, and it has been there through the ALEX trial. I was a PI on the ALEX trial way back 5-6 years ago in the US. And now you have ALK-directed treatment happening with significant response in this patient. But then down the line, as I mentioned, you can develop progression on ALK inhibition due to pathway of resistance. So this patient develops a brain metastasis, which is common and seen in 40% of ALK positive patients. Then what do? You put them on a newer drug, which is another ALK inhibitor, which targets many, many resistant pathways called lorlatinib. It's already in the country. And you can see that this patient responded, lived on for several years after the ALK inhibition. Then you have the ROS1 fusion. Again, ROS-directed therapy. Many new drugs that have come through. We start with crizotinib, but we have enterectinib, we have pralsetinib. Many drugs that can be utilized for ULK inhibition. And this picture is worth 1,000 words. You can see the amount of disease in the PET scan, right as if a football is sitting on the chest, and just with crizotinib, the disease melted but developed a pathway of resistance. This is an image on lorlatinib. And so with lorlatinib, the disease just went away because you targeted the pathway of resistance. Then comes in the BRAF mutation in non-small cell lung cancer. And when you look at the BRAF mutation, the BRAF pathway actually goes through BRAF V600E, for which we have an inhibitor. Earlier, it was vemurafenib. Now we have dabrafenib. It is a pathway that is highly active in melanoma. It's also active in lung cancer. It's also active in some kinds of colorectal cancer and thyroid cancers. You do see rare BRAF mutations also, but these are the major malignancies where we see BRAF. So what happens if you target BRAF? If you target BRAF, downstream pathway MEK becomes active, and these patients can develop squamous cell carcinomas of skin. So what do you do? For BRAF positive patients, you have to target BRAF and MEK. So you have to use dual inhibition, BRAF inhibitor and MEK inhibitor. The MEK inhibitor is trametinib and the BRAF inhibitor is dabrafenib. Both these drugs are available in the country. And once you target both these pathways, you're able to get significant results, huge response rates, and durable responses seen. These are drugs that are very well tolerated, can be given to the elderly, to the weak, to the frail, and excellent results. I have patients who are very frail because BRAF, for some reason, is seen in elderly patients. And so I have lung cancer patients on just dual inhibition when they were dreading being treated with chemotherapy. You can see that the liver, the lung, the mediastinal lesions, all of them are gone. The cough, the raspy cough that was not going away with chemotherapy is all gone as well. We have MET gene mutation, we have MET amplification that can get targeted with the MET inhibitors. Capmatinib is a drug that is available in India already and doing wonders in a lot of our patients. Before capmatinib, one of the drugs that is presented as an ULK inhibitor and a ROS1 inhibitor, a drug called crizotinib, was actually initially, when I was at Dana-Farber, being developed as a MET inhibitor. So I know that it had very strong MET activity. Fast forward to now, when the drugs, capmatinib was not available in the country for MET inhibition, but crizotinib was. One could use in a MET positive patient, you could still use non-formulary off-label crizotinib for these patients to control the disease and get excellent results for MET. Many times you can see in an EGFR positive patient, MET mutation develop as a pathway of resistance. What if that happens? You leave the patient on the EGFR inhibitor with osimertinib and you add the MET inhibitor with crizotinib. Many clinical trials running in the country actually addressing dual pathway inhibition for these patients after understanding the pathway of resistance and targeting dual pathways for these patients free of cost. So you have to look out for clinical trials. There are novel trials coming in the country. There are drugs already launched, and capmatinib is one drug that is already launched, available with Novartis, that can help in MET positive patients. So you have a MET positive patient here with brain metastasis and an excellent blood-brain barrier penetration with capmatinib, which is a pill, oral pill, and really transformative in disease control. I treated 2 elderly patients most recently with capmatinib and osimertinib combination. And one such result is right here, where you can see huge amount of disease in the retroperitoneal area. All of that disappears in the lung, in the retroperitoneum, in the bone, all of that gone on MET inhibitor capmatinib. The newest kid on the block is KRAS mutations. What does KRAS mutation do? KRAS mutation leads to very aggressive type of lung cancer. And earlier we would give MEK inhibitors for these patients, but they weren't that effective. Now you have sotorasib, which is the new kid on the block, the newest drug approved for KRAS G12C mutation inhibition, and has been transformative in really treatment of KRAS positive lung cancer. What we have today is the presence of KRAS inhibitors, not just with sotorasib, but multiple other KRAS inhibitors that are available in clinical trials, providing excellent disease control in terms of responses, durable responses, progression-free survival advantage and survival advantage, and preserving quality of life. Then you have the RET rearrangement. What does RET rearrangement do? Again, similar to what we saw with the ALK rearrangement, these drugs are actually quite tough. The diseases are quite tough. They can cause very widespread disease, aggressive disease, and actually best addressed with inhibition through the pathway. So we have RET inhibitors available in the country, selpercatinib and pralsetinib, both again target the RET pathway and are transformative in disease control. So much so that alongside the 5 biomarkers that I described earlier, MET and RET are routine targets that I test for. And that is why instead of testing for each pathway separately and 10,000 per pathway, you now do next generation sequencing where the 400, 500 gene panels are tested, DNA, RNA fusions are tested all together to give us the answer of which pathway may be active in that patient and how to target it the best. And you just with the RET inhibitor drug, you can see here the waterfall plot of response and how these lesions have responded significantly by starting them on oral therapy drugs. 60% response rate, 100% disease control rate, availability in CNS, well tolerated, breakthrough designation. I think the pathway-directed therapy is truly transformative in lung cancer. Time has come when we need to truly recognize the pathways. We have to play detective. You have to stop everything and think, if this is a non-smoker patient, this patient is a prototype for driver mutation positive lung cancer. We test for the drivers till we find them. And this is a selpercatinib RET inhibitor where you can see magical response to treatment very quickly just on oral treatment for these patients. So I finish with this slide from Back to the Future, where I say the future is now. It's time for precision oncology. The message that I leave you with is, when I said medical malpractice, it was a strong phrase, but I borrowed it from a world leader, Narges Duma, who's a South American world leader, now leading lung cancer in the US. These are her words. And I think they can't describe this point better, that you have to really be diligent before you offer bucket treatment to a patient who appears to be driven by a driver mutation in lung cancer. Targeted therapy is written on the wall for such a patient. We as clinicians have to have ownership, responsibility in testing enough. If you did an initial test and you did single gene analysis and you didn't find it, that the job is not over. You do a rebiopsy. There's a concept called tumor heterogeneity. You need to do a rebiopsy and you need to retest. And the testing method could be different. You could be doing a FISH testing. You could be doing an NGS testing. You could be doing a liquid biopsy, because tumor heterogeneity sometimes manifests as a ctDNA abnormality in the blood. And you need to test the blood to figure out whether the mutation will show up in the blood. So using complementary tests to come to the diagnosis is very critical. If you look, and you don't find still, you document and you talk to the patient, you put it on the table that the patient may still be a driver mutation positive. And that's when you can use alternate treatments. In such situations, I tend to utilize combinations that were given and propagated in driver mutation positive lung cancer. And that combination is not just chemo plus immuno, it's actually chemo plus immuno plus target therapy, all given intravenous. It's Empower 150 regimen with minimal data, but more data needs to come in. In nutshell, It is time for precision oncology, and lung cancer is the poster child for precision. I hope I was able to convey this message to you early morning on Sunday, and I hope I was able to wake you up a little bit. Thank you very much for listening.
Thank you very much.
You have not waken us up, you have shaken us up.
It was a very informative lecture.
Thank you. Thank you so much.
Any questions from the panelists?
There's one question asking, when would a patient be advised for a lung transplant? So unfortunately, cancer patients generally are not candidates for lung transplant. So in routine situations, we don't recommend lung transplants for such patients, because if there is a localized lesion, you can actually surgically take it out. For stage 1 lesions, there's equal data for stereotactic body radiotherapy, SBRT, and surgical removal. For, let's say there's a patient with lung capacity that is poor, and you can't do a full lobectomy. You can do a wedge resection, or you can do focused SBRT to that lesion. So definitive treatment, localized definitive treatment can also be done in these patients, and they don't need to lose their lung. When it is advanced disease, which is the name of the game in at least 60%, a third of patients of lung cancer present with locally advanced or advanced disease. That's the harsh reality. In such patients, you cannot really transplant the lung because the disease is systemic and could come back anywhere. So we believe that it is systemic treatment and not removal or replacement of the lung that gives longevity.
So if the lung cancer is met secondary to some primary, then how do we approach it?
Yes, sir. So with secondary lesions, for example, head and neck cancer patients can have lung mets, very common.
Or liver cancer.
Or liver cancer can go to lung mets. So we see whether there are lesions that can be treated with localized treatment. For example, if the lesions are 3 or less than 3, some people even go to 5 or less than 5, it will still qualify as oligometastatic disease. In such situations, I would do systemic treatment, and I would also give localized treatment, which could be focused SBRT to those 3 areas. I call it curative approach, because once it is spread, we are not supposed to use the word cure, but you can attempt a cure. Sometimes, not knowing the biology, if you do localized treatment, you can stop the disease from coming back. But systemic treatment in such situations would still be important. So whether it's chemotherapy, whether it's targeted therapy, immunotherapy, whatever that biology defines, one will have to give systemic treatment to the patient. But you could, for oligometastatic disease, approach the patient with a curative intention. And give
I have one question.
Yes, sir.
How to differentiate primary and secondary lesions in lung cancer?
Wonderful question. So I am treating a patient right now who had lung lesion, 2.5 centimeters, and then on left side and on right side, small, 3-4 lesions. So we biopsied the lung lesion, and the lung lesion was not TTF1 positive. So it's adenocarcinoma, but TTF1 is a signature of adenocarcinoma lung, and that was adenocarcinoma negative, TTF1 negative. And so this patient, upon multiple reviews, including Dr. Borges' review, turned out to be having an IHC that is consistent with GI primary. So you then start looking in the PET scan whether there is a GI lesion. And similarly, in a patient with gastric cancer who presented with lung mets, one found a GI primary, an ulcer in the gastric antrum. So histopathology is the cornerstone to figure out whether this is primary or secondary. And of course, the clinical history of that patient, PET scan, and the lookout for a primary lesion elsewhere in the body through the PET scan. Sometimes we even need to do nuanced testing with additional invasive like endoscopy, colonoscopy may be required. Rectal cancers can go to the lungs. So you may need to do a colonoscopy or a sigmoidoscopy in a patient to figure out if there is a lesion that was picked up on the PET scan. You will need to confirm it with an invasive testing. Invasive testings are not encouraged anymore when we are not able to figure out primaries. We only go up to PET scan. If there is, on a diligent lookout on the PET scan, if there is a lesion seen, that's when we go ahead to do invasive. And other than that, it's histopathology and imaging. I think there's a question here which I would quickly answer. What will be the lifespan with chemotherapy? Earlier we would say 1.5 years was the median lifespan for stage 4 lung cancer. This number has severely been challenged now. Around 30% of lung cancer patients have lived for 5 years and over with immunotherapy in patients who were candidates for immunotherapy. So the margin, the envelope is getting pushed. I have a patient who I treated as one of my first immunotherapy patients in the US. And that patient, we sat down and we told him he had 1.5 years to live. Everybody cried. The patient cried, the family cried, the children were going off to college, everybody cried. And that patient then went on to receive immunotherapy. And I've said this story many, many times. I still look him up on Columbia Board of Trustees. And he's still alive to tell his story. So it is really a very transformative time where one size fits all doesn't stand true anymore. Each patient is special. I try not to give any pessimistic answer to any patient. And if someone really pushes me before I have the biomarker results, I tell them this very, very blatantly, that I'm not going to give out a negative answer. I'm very resistant to giving out a negative answer of months and very short period of time, because in lung cancer, you really don't know. This patient could live forever.
Yeah.
Okay.
So I think we've asked all questions, and hopefully I've been able to give out some salient messages. And thank you so much for having me today to convey my passion.
Thank you. It was a pleasure listening to you.
Thank you very much, Dr. Limia.
Thank you, sir.
Okay, now we move on to the next speaker for today, Dr. Darshana Rane. I will request our Assistant Secretary, IMA CGP, Mumbai Subfaculty, Dr. Kashyap Dakshini, to introduce Dr. Darshana Rane.
Good morning, friends. Dr. Darshana Rane is a consultant medical oncologist at Mumbai Oncology Center, Dadar. Dr. Rane is also attached to Sushrusha Hospital, Dhanvantari Hospital, Wockhardt Hospital, Bombay Central, HCG, Borivali, and Surya Hospital, Andheri. Dr. Rane is a consultant medical oncologist also at Nanavati Super Speciality Hospital. She pursued her MBBS from Terna Medical College, MUHS, DNB Internal Medicine from KEM Hospital, Pune, followed by DNB in Medical Oncology and Hemato-Oncology from Prince Ali Khan Hospital, Mumbai. She then received ECMO, that is European Society Certification in Medical Oncology. She is an esteemed member of the American Society of Clinical Oncology, that is ASCO, and the European Society of Medical Oncology. Her areas of interest are chemotherapy, acute lymphocytic leukemia, breast biopsy, cervical cancer treatment, endometrial cancer treatment, leukemia in children, liver cancer, lung cancer, etc. Today, she will be talking to us on management of lung cancer.
Dr. Darshana, please, you are unmute yourself.
Unmute yourself.
Oh, sorry. Good morning, all. Thank you so much for the warm welcome. With that, I guess Madam has spoken a lot on lung cancer management already. Probably my lecture should have been before hers because I will be just touching on the very basic. Please allow me to share the screen. Is my screen visible?
Yeah, it's visible.
I mean a PowerPoint?
Yes.
Okay, thank you so much. The topic given to me is lung cancer management. So as we all know, lung cancer is one of the common cancer in the world and second only common to the breast cancer in the world. Estimated 2.2 million new cases. And though it was more common in men, now we are seeing increasing incidence in women. It's the most common cause of death worldwide. And in India, though, the lung cancer is ranked not the second most common, but the fourth most common type of lung cancer. And we all know the main histological types are the non-small cell cancer, mainly the adenocarcinoma, squamous carcinoma, large cell, and the small cell carcinoma. And they are distributed as per the pie chart given. So majority, around 85% of the non-small cell carcinoma that we see today. And there are 5 main causes. One is the smoking and associated carcinogens, radon gas, which is the byproduct of uranium. Asbestos comes from the asbestos industry, also causing mesothelioma, air pollution, genetics, and the most common in women is because of the second-hand smoke. And other lung diseases like the chronic disease of COPD, pulmonary fibrosis, previous radiation to the breast in case of a breast cancer or a Hodgkin's lymphoma, and family history, though the incidence in family history is hardly 10 to 15%. In India, lung cancer accounts for 13.3% of all new cases and also the most common cancer-related deaths. And yes, it's the fourth common cancer. In males, it is ranked second, while in females, the sixth. And non-small cell cancer constitutes 75 to 80%. Majority are in the advanced stages. The staging is categorized from stage 1 to stage 4 based on how much the lung cancer has spread. And the mortality also depends on the lung cancer stage. So localized disease, lung cancer at diagnosis is hardly 15% and 5-year survival 50%. Regional spread to the nodes 25% incidence and survival 20%. Distant metastasis more than 55% and less than 1% survival was there previously. But now with the advent of the newer therapeutic modalities, mainly the targeted therapy and immunotherapy, this less than 1% is seriously is challenged because now we are reporting more amount of the 5-year survival is the most in the one with meds, thanks to the targeted therapy. Signs of lung cancer are so common with the other lung-related diseases like wheezing, shortness of breath, persistent of worsening of cough, hoarseness, coughing up of blood, and bronchitis, chest pain. And the most commonly done tests are initially we do a chest X-ray, CT scan, bronchoscopy. But mainly when the patient comes to us, what we do is the PET CT scan, which helps us to detect the presence of lung cancer from head to foot. And MRI CT brain is done, CT brain, not the plain, with the contrast, is done when you're looking for CNS involvement. This is especially done in all cases of small cell cancer, and it is done in the advanced stages of lung cancer who was non-small cell who are symptomatic. A pulmonary function test is done in certain cases. Sputum cytology to see associated presence of tuberculosis if you are suspecting. But main stay is the biopsy. Biopsy is very important, be it the bronchoscopic biopsy or a CT-guided biopsy. And if at all the biopsy is not possible, then we do use the pleural fluid cytology, and the pleural fluid cytology followed by cytospin and a cell block that can also be used to run the IHC and other tests. Thoracoscopy is really avoided. It's done in very unfortunate cases. There is one more test called liquid biopsy. That is the blood sample is taken to assess the type of lung cancer, and that is done in those who are very frail and in whom we cannot do the biopsy. So this is just a depiction. So the most important thing done today, especially in case of advanced lung cancer, the mutational analysis for the driver mutation. So after IHC evaluation and one has understood that it is an adenocarcinoma or the small cell carcinoma or the squamous, etc., one subjects mainly the adenocarcinoma and the squamous carcinoma for the mutational analysis for the driver mutations. Most commonly EGFR, ALK, ROS, and then nowadays PDL1, and then there are others, MET, HER2, etc. We do get a panel for the same, and it can so basically immunotherapy marker is the PDL1, and we also do genomic profiling. Next generation sequencing is the test, and that determines not just the mutation, but also they would tell us what type of chemotherapy or targeted therapy the cancer will benefit from. So as we all know, the treatment, mainly surgery, radiation, chemotherapy, but now the new kid on the block is immunotherapy, which is used quite widely in the lung cancer. Surgical resections could be wedge resection, segmental, lobectomy, or the entire lung could be removed, pneumolectomy. But the incidence of such surgeries are decreased because one, there is the patients do not really come in a very early stage, and then second is we deal with many patients with beautiful targeted therapeutic approaches. So another is important is the radiation therapy, which is very important, especially in the squamous cell carcinoma. We also use radiation therapy for palliative intent for controlling pain and other symptoms such as if there's a bone mets in the ribs, on the spine, then or in the brain, we use radiation therapy with the palliative intent. Let me focus on systemic therapy, which is my domain. So we have chemotherapy, targeted therapy, immunotherapy. Systemic therapy means that the drug is injected or taken by mouth, or that drug acts from head to foot. So that is the beauty of the systemic therapy. And so surgical resections can be done probably in only 30 to 35% because very few patients are in the early risk group. But most important is the chemotherapy. After surgical resection, the chemotherapy that we give is called as adjuvant chemotherapy, and usually it is offered to stage 1 to stage 3A. But 80% lung are inoperable, and hence they are more subjected to the palliative kind of a chemotherapy. Though chemotherapy, just the chemotherapy alone does not have a curative role, but yes, it does improve the overall survival and the disease-free survival. So stage 3B and stage 4 are the ones which we commonly see, and hence this is a very important role to play. The chemotherapy that we use is basically driven by how the performance status of the patient is. So maybe a single agent or a combination therapy. For the very fit ones, we use generally a doublet combination therapy using a platinum backbone, and usually we also combine it with a targeted therapy. So be it either the conventional targeted therapy or the immunotherapy, it is used in combination. It can be used in combination with radiation therapy as a concurrent chemoradiation in squamous cell carcinoma. So before surgery, after surgery, or as a palliative treatment, chemotherapy is used. And yes, chemotherapy is slightly toxic, but yes, what is the beauty of chemotherapy? It acts very fast. So chemotherapy is basically used to immediately control the symptoms. So now targeted therapy, so we know that there are these driver mutations, and so mutations are caused by multiple causes. There are somatic mutations, passenger mutations, and the cancer is evolved from a normal cell by the mutations to a cancer cell. And these multiple mutations are targeted, and a therapeutic approach is identified to target these mutations, and this is called a targeted therapy. So mutations, more than 50% lung cancer and 1/3 of the small cell cancer can be characterized by driver mutation profile. This enables the use of specific inhibitors of such mutations. Mainly they are oral medications, so they are less toxic compared to the chemotherapy. So EGFR is a strong predictor of the efficacy of inhibitor to EGFR therapy, and this is one type of mutation that is seen. And so there is a molecular subtyping that we do. Mainly it's restricted to adeno and the squamous cell carcinoma. And here's a list. There is ALK, HER2, BRAF, PIK3, AKT, MAP, NRAS, ROS, RET, KRAS, EGFR, and almost all, except for a few, almost all the mutations have a targeted therapy available today in the market, be it oral or intravenous. So majority of non-small adenocarcinoma have identifiable driver mutations, and the most common mutations are KRAS, EGFR, KRAS, ALK, and these can be also assessed by a simple test of with IHC. So, so what has happened is in lung cancer, the majority, the ones which are non-small cell lung cancer, they have these driver mutations. So now it's just not, you know, initially we used to just modify our treatment based on whether it was adeno or squamous or large cell or small cell, but now it is not so. Now it is actually divided based on which mutation that patient is having, and basically if someone would ask what is the survival, it would really vary based on what mutation the patient has and how the patient responds to each the targeted therapy that is offered. And also the targeted therapy has moved on to such advances that now there is not just one targeted therapy. We have a first line, second line, third line target therapy for almost each of the targets that are there. So EGFR mutation, global and Asia burden around 10% in Caucasians, 25 to 60% in Asian, and India has around 25 to 50% in various studies. So Indians are a bit typically not in typical Caucasian, not typical Asians, which are mainly, which they consider mainly the Southeast Asians. So EGFR activating mutations tend to cluster in exon 18 through 21 in non-small cell cancer, and most commonly is in exon 21. And what we also understand that if there is a mutation in exon 20, then most of these targetable mutations, targetable therapy, they do not work. So it's very important to understand, even though it's an EGFR, at which exon is the mutation, because our targeted therapy would really be used accordingly. So, so these are there's a huge list of which therapy you can choose for each of the mutations, and as you can see, there's just not one or two drug, but there's a big list. And yes, these are used even as a first line, as an upfront setting, wherein we understand the mutation and then we straight away offer the mutation. Some of these we straight away offer the targeted therapy. Some of these targeted therapy also do penetrate the brain. So they are also used for metastatic cases with brain mets as a first line agent if the patient does not have any symptoms with respect to the brain mets. Then the new kid on the block that we have is immunotherapy. So what is immunotherapy? So immunotherapy is basically our body has certain immunity which we develop to the tumor cells, and this immunity is a T cell based immunity, and the T cells, they try to develop certain receptors towards the tumor cells. Now what happens, immunotherapy, what it can do is they block the tumor cells from deactivating of the T cells. So the main role, as you see on this diagram, on the T cell, there is a PD-1 receptor. On the cancer cell, there's a PD-L1 receptor. And there is a, PD-1 and PD-L1, they both interact normally. And this is how the T cell immunity is driven when the cancer cell prevents the T cells from destroying them. But what the immunotherapy does is they block either the PD-L1 or the PD-1, and that's how they try to develop the immunotherapy. So what drugs do we have? We have PD-1 inhibitors, nivolumab, pembrolizumab, PD-L1 inhibitors, atezolizumab, durvalumab, avelumab. And immunotherapy basically it tries to modify the immune system, wherein the immune system becomes stronger, and immune system tries to attack the cancer cells. But one important thing in immunotherapy, one, it's very costly, and immunotherapy responds to hardly 30 to 40% of the individuals. So one size does not fit all. And so what do we understand? Establishing the diagnosis is very important. FNAC has no role. We do require a biopsy. Determine the histological subtype, and more important is determine the molecular profile for the tumor. Why? Because it's very important in terms of treatment. Yes, the responses are in few months or maybe a year or two for those who respond, but it is significant. So again, what I said, if we don't get the adequate sample, we are not able to do a biopsy, what we can do is liquid biopsy. So liquid biopsy is nothing but taking a sample of blood and evaluating the circulating free DNA, and that is shared from the tumor into the bloodstream, and that is being evaluated for what mutations it is and what is the type. So current treatment paradigm of molecular biomarker positive advanced non-small cell lung cancer is very, very important. And we do understand that now the advance of the metastatic lung cancer is no more bad sign. It's actually, we are more benefited with these molecular biomarkers, and we can really treat them more better than the stage 3 and the stage 2 ones. So definitely also there are these certain targeted therapy like the anti-VEGF inhibitors which we use, like bevacizumab. So it is a standard of care in the current world, and what the survival we would see in case of lung cancer of around 8 months, improved with certain agents. And though it is a small increase, but definitely the survival has increased gradually, and hence it is a very important step advance in the management of the lung cancer. With that, I thank you all for the patient hearing.
What you said was right. Your lecture should have been before.
Yeah.
The bad throat.
Anyone with the questions?
Yes, Dr. Howard.
No, there are no questions as such.
Actually, madam must have solved all the questions before.
Oh, no.
Yeah, there were 2, 3.
Your talk was very nice.
Thank you.
Okay. Thank you very much. Now we move on to the next speaker. I will request member IMA CGP, Dr. Komal Jatania, to please introduce Dr. Rohan Aurangabadwala. Dr. Komal.
Thank you, ma'am. Welcome all. Dr. Rohan Aurangabadwala is a consultant pulmonologist attached to Apollo Hospitals, Navi Mumbai. He has worked as an assistant professor in the Department of Pulmonary Medicine at Terna Medical College and Hospital, Nerul, Navi Mumbai. After passing MBBS from TN Medical College, Mumbai, he did his MD in Respiratory Medicine from SMS Medical College, Jaipur. He has been trained in interventional pulmonology and critical care at Apollo Hospital, Bangalore, as well as at the Respiratory Institute, Department of Pulmonary Medicine, Cleveland Clinic, Ohio, USA. He has many publications in indexed medical journals. He has written chapter on bronchoscopy in the Manual of ICU Procedures by Mohan Gurjar. He is a life member of Indian Association of Bronchology and Indian Society of Critical Care Medicine. Today, he will be talking to us on smart approach for management of asthma. Welcome, Dr. Aurangabadwala.
You can start.
Yeah, thank you for the kind introduction. And let me just allow me to share the screen.
Yes, we can see.
Yeah, just a second. Yeah, so today's topic is going to be asthma management smart approach. We'll have a brief discussion starting with introduction to asthma, diagnosis of asthma, assessment and management of asthma, what exactly is the smart approach for the treatment of asthma, importance of the inhaler devices, a small brief as to what you should do with the still ongoing pandemic. So why are you even discussing the management of asthma? Though it seems to be very easy, it is still probably one of the most, as in inappropriately treated diseases, if we look at. And it's one of the most common chronic disorders worldwide, with an estimated 300 million prevalence. And it is increasing day by day. The prevalence of asthma is increasing in many countries, including adults as in children. It's also a major cause of absenteeism from work and school, and leads to a significant amount of morbidity and mortality. And the amount of healthcare expenditure on asthma is staggeringly high. And that is why it is important that we treat asthma appropriately to reduce the burden of this disease. Now, how do you define asthma? It's an heterogeneous disease which is characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheezing, shortness of breath, chest tightness, and cough that can vary over time and in intensity, along with variable expiratory airflow limitation. This variable expiratory airflow limitation is very important in making the diagnosis of asthma. So how do you diagnose asthma? It is basically on two things. It is the characteristic symptom pattern of asthma, along with evidence of variable airflow limitation, which can be established with the help of bronchodilator reversibility testing and other tests. It is characterized by airway inflammation and airway hyperresponsiveness. These are the two important characteristics as far as asthma is concerned. Now, when you're trying to diagnose asthma based on symptoms, there are a few set of symptoms which would increase the probability of the diagnosis of asthma. That is, if you have more than one coexisting symptom, it could be wheezing, shortness of breath, chest tightness, cough. Also, the symptoms are usually much more worse at night or early in the mornings. They tend to vary over time and in intensity. So patients will present to you with a classical history of having episodic symptoms. There are periods when they have worse times. There are periods when they are absolutely fine. And most of the times, these symptoms are triggered either by viral infections, exercise, exposure to allergens, change in weather, excessive laughing, or excessive emotional outbursts, irritants such as car exhaust fumes, smoke, or even strong smells of perfumes. However, the chances of the symptoms being because of asthma is low if you only have isolated symptoms, which can be only an isolated cough, or there could be only chronic sputum production, which is more common in COPD, or if your shortness of breath is associated with dizziness, lightheadedness, all of which could be sometimes because of symptoms, because of pulmonary embolism, and so on and so forth. Or if you have only chest pain as the presenting symptom, or if you have exercise-induced dyspnea with noisy inspiration. So all that is noisy doesn't necessarily mean is asthma. This could just be stridor. So you have to be very careful when you are assessing the patient. Now, how do you confirm? So one is the set of symptoms which will help you to make the diagnosis of asthma. The second is your pulmonary function test. Documentation of variable airflow limitation on a PFT is very important to make a diagnosis of asthma. And how do you do that? One, you need to have an obstructive pattern on the PFT. What do you mean by an obstructive pattern on the PFT? The FEV1 FVC ratio should be less than 70% or less than 0.7. Normally, it's between 75 to 80%. And once you have an obstructive pattern, you need to document a reversibility or a responsiveness of FEV1 to a bronchodilator. What we usually do is we do a pre-bronchodilator testing, give bronchodilator, which is usually a short-acting beta agonist like salbutamol. And after 15 minutes, we do the second part of the test, which is the post-bronchodilator. And if the post-bronchodilator testing shows an improvement or an increase in FEV1 by 12% and 200 ml, both of which are important, then a diagnosis of asthma can be confirmed. And the certainty of the diagnosis of asthma increases if the increase in FEV1 is more than 15% and 400 ml. Other way of confirming it is by using peak expiratory flows, but peak expiratory flows are less accurate as compared to the proper pulmonary function testing. Now, if you look at the spirometry reports which come across, it is important to see the appropriateness of the spirometry tracings. A minimum blow of 6 seconds. If you look at this graph of volume versus time, you see that there is a 6-second expiration, which is ideal. Anything more than 4-second expiration is acceptable. And if the blow is less than 4 seconds, probably you will have to interpret the PFT cautiously. Now, once you have the volume time loop, you also look at the flow volume loop. There is a characteristic shape of the flow volume loop, which is seen with an obstructive pattern. The one in the red is the pre-bronchodilator. You can see there is a concavity here. It sometimes in severe obstruction, you can see what is known as a rat tail appearance. And after the bronchodilator, you can see there is an improvement in the lung function. So this characteristic pattern on the PFT along with post-bronchodilator response is essential for the diagnosis of asthma. In addition to your symptoms and the PFT, also your physical examination is important. A lot of time you may hear the classical polyphonic wheezing and auscultation. And sometimes if it's not possible, you can actually make a person exhale forcefully, maybe in the form of coughing, and you may be able to hear a wheeze. But a lot of time the examination may be completely normal. But it is also important to understand that wheezing does not happen only with asthma. It can happen with a lot of other conditions, including respiratory infections, COPD, presence of upper airway dysfunction, endobronchial obstruction, or sometimes with an inhaled foreign body. What happens with endobronchial obstruction and inhaled foreign bodies is most of the times, if they are in a bronchial tree, they lead to unilateral wheezing. So if you actually get a unilateral wheezing, it could be because of endobronchial obstruction, foreign bodies, or sometimes because of localized bronchiectasis. Now, once you have established the diagnosis of asthma, it is important to assess what is the patient's condition as far as asthma is concerned. So you look at two domains as far as assessment of asthma goes. One is asthma control in terms of control over the last 4 weeks. Also, at the same time, you assess for the risk factors for poor outcome in that particular patient, which could be documentation of maybe a low lung function. Once you have assessed the asthma control, if there is a patient who has already been on treatment, you should check whether the inhaler technique and adherence is correct. You should inquire about any side effects which are related to the medications they are taking. You should assess whether they have a written action plan and understand what is their understanding of asthma, what is their attitude towards asthma, and what are their perceived goals as far as the treatment of asthma goes. Now, if somebody is not on treatment, you would like to start with the treatment with the basic strategy of starting an inhaled bronchodilator and corticosteroid. Now, in addition to assessing the control of asthma and the treatment issues, it is also important that we look at the coexisting illnesses or comorbidities. A lot of time, it is these comorbidities which are untreated that are responsible for the persistence of symptoms of asthma and a poor quality of life. And what are these comorbidities? Allergic rhinitis, rhinosinusitis, gastroesophageal reflux disease, obesity, presence of obstructive sleep apnea, a lot of emotional disturbance in the form of depression, anxiety. So all of these comorbidities also need to be assessed and addressed so as to do justice to the patients and treat them effectively. Now, when we are talking about asthma control, how would you establish whether a patient of asthma who is on treatment is adequately controlled or not? So when you're talking of control, you look at 4 things: whether the patient is having presence of daytime symptoms more than twice in a week. Is there any nighttime awakening due to asthma? Is there a need for reliever medication more than twice in a week? Or is there presence of any limitation in activity? If a patient answers none of this, as in none of these are present, it is said that a patient is well controlled as far as asthma goes. If answer to any 1 or 2 of these are positive, is partly controlled. If answer is positive to 3, it's present to 3 or 4 of these questions, it is uncontrolled asthma. Most of the times, if you have nighttime disturbances, it automatically qualifies as uncontrolled asthma. Once you have looked at the control of asthma, you should also assess for risk factors on a periodic basis. What do you mean by risk factors? You look at risk factors which are responsible for exacerbation, risk factors which can lead to a fixed airflow limitation. So if you do not treat asthma appropriately, what is reversible in terms of airflow limitation over a period of time becomes fixed, which is not desirable. And you should also assess for the side effects of the medications. So let's take each of them one by one. What are the risk factors for exacerbation? If a patient gives a history of requiring intubation and mechanical ventilation, or who has uncontrolled asthma symptoms, these are major risk factors for having future exacerbations. If a patient has had more than 1 exacerbation in the last 12 months, it again says that there is a high risk for subsequent exacerbations. Low FEV1 at the time of initial testing, if it is less than 60% of predicted, again carries a risk for future exacerbations. So you should assess lung functions periodically when you are treating a patient. You should do one at the baseline, then you should do one at 3 to 6 months, and then periodically thereafter. Why is it essential to do a baseline PFT or lung function? One, absolutely to establish the diagnosis, but also to stratify these risk factors. And if you do not do that at baseline and you really start treatment without a baseline PFT, if it is asthma and the patient gets better, it is difficult to depict the reversibility later on once you have started treatment. So do the baseline PFT, which is important. Also, use of incorrect technique of inhaler, poor adherence to inhaler increases the risk for exacerbation. Ongoing smoking is a risk factor for exacerbations. Obesity, pregnancy can also lead to worsening of asthma, and they are independent risk factors for an exacerbation of asthma. Now, what are the risk factors for fixed airflow limitation? As I said, if you do not treat asthma appropriately, it will lead to fixed airflow limitation. So, absence of inhaled corticosteroids in the treatment, ongoing smoking, ongoing occupational exposure to allergens or factors which are responsible for asthma, these can lead to fixed airflow limitation. And what are the risk factors for side effects? Frequent requirement of oral corticosteroids or very high doses of inhaled corticosteroids can again lead to side effects. So it is important that we make sure that patients are treated appropriately to reduce all these risk factors of asthma. Now, once you have established the control and looked at the risk for exacerbations, you should also assess the severity of underlying asthma. And how do you assess the severity? You assess severity once you have put a patient on the controller treatment. It's usually a retrospective thing. Somebody gets controlled well on a very low dose of inhaled corticosteroids, it would qualify as mild asthma. And this severity can actually be changing. It is not static. It can change over a period of year or month. And as the severity changes, you'll have to change your treatment strategy, which we'll come to later in the talk. So how do you categorize the severity? You categorize it as mild, which is asthma, which is well controlled with step 1 or 2 of treatment, that is low dose inhaled corticosteroids. You classify it as moderate if you're well controlled with step 3, which is low dose ICS and LABA. And you may qualify, classify a patient as having severe asthma if he requires step 4 or step 5 of treatment as per the GINA guidelines, where they require high dose inhaled corticosteroids and add-on treatments, or they do not get controlled despite optimal treatment. So that is why it is important to categorize your patients based on the severity of their symptoms. So this will help you guide the further management. Now, as far as the management of asthma goes, what is the main goal of asthma management? One, it is the overall control of asthma. The overall control of asthma not only looks at the current control, which is basically relief of symptoms, reducing the use of relievers, maintaining your physical activity, and maintaining the lung function, but it also looks at reducing the future risk of exacerbations, reducing the risk of worsening of lung function, loss of lung function, worsening of symptoms, and reduces the chances of adverse effects of medication. So you should be trying to establish an appropriate current control of treatment, which will go a long way in reducing the future risk related to uncontrolled asthma. And that is why it is important to understand where would you start your treatment. So this is as per the GINA guidelines. GINA stands for the Global Initiative for Asthma. It's a very easy thing to understand. Once you have assessed a patient and confirmed the diagnosis of asthma, you should look at the level of symptoms, look at the comorbidities, and then you can initiate the treatment. If you have, now what has happened in the last 3 years since 2020 is GINA has made some important changes. Initially, in the step 1 or 2 of treatment, it used to be as and when required short-acting beta agonists, which has changed. Now, GINA categorically states that the preferred treatment would be using a low-dose ICS formoterol combination for the treatment of asthma. So even in the first and second step of asthma treatment, what do you mean by first and second step? Patients who have infrequent symptoms, that is less than 4 to 5 days in a week, they complained of symptoms, you would start them with a low dose ICS formoterol combination. SHABA is almost out. So that is labeled by GINA as track 1. That is the preferred track of treatment. And subsequent steps, you go up on the treatment if the patient is not getting controlled or if he has more symptoms. Step 3 is for patients who have symptoms most of the days or who have nighttime awakenings because of asthma once or more in a week. Step 4 would be daily symptoms or a low lung function, where you would require medium dose maintenance therapy with ICS and formoterol. ICS stands for inhaled corticosteroids. And step 5 is severe asthma, where you would need high dose inhaled corticosteroids formoterol. And if still not controlled, you will add on maybe a long-acting muscarinic agent like tiotropium, or even that is not sufficient, then you would add on other forms of therapy, which could be the anti-IG, anti-interleukin 4 and anti-interleukin 5. So the top part of the chart shows the preferred track or the track 1. And the second part is the alternative in case the patient does not want to take inhaled corticosteroids and formoterol as a reliever, where they can use SABA, but it's strictly speaking is not a great option. Now, why is it important that inhaled corticosteroid and formoterol be introduced even from step 1? Is because if you look at studies over a period of years, it is understood that asthma control can be poor even in patients who are at the step 1 of GINA treatment. So presence of lesser symptoms doesn't mean that your asthma is well controlled. So if you look at this graph here, even even in the step 1 of treatment, as high as 52% of the patients had uncontrolled asthma, and this progressively increases as you move forward from step 2 to step 3, 4, and 5. So a huge proportion of patients are having uncontrolled asthma despite being on treatment, and that is why it is important to have the appropriate treatment started. Now, why was this control not being established? As per, if you look at most prescriptions of patients who come to you would understand a lot of them are only on a short-acting beta agonist, and this overuse of beta agonist is a problem. A lot of time the inhaled corticosteroid is absolutely missing. Now, if you look at this study by Patel et al., it is shown that even those who are on a maintenance inhaled corticosteroid and LABA and using beta agonist, short-acting beta agonist like salbutamol as a reliever, whenever they had worsening of symptoms, they would keep increasing the usage of salbutamol to the extent of almost 24 inhalations in a day prior to reaching a hospital with a severe exacerbation. So this excessive SABA usage leads to a delay in seeking medical help and leads to exacerbations. Also, what happens with excessive use of SABA? It leads to downregulation of beta receptors, which will in turn lead to decreased bronchoprotection. That is, use of beta, downregulation of beta receptors will not lead to adequate bronchodilation with overuse of SABA. There will be a rebound hyperresponsiveness and a decreased bronchodilator response. And why does this rebound hyperresponsiveness and decreased bronchodilation happen? That is because excessive use of SABA leads to increased airway inflammation or eosinophilic airway inflammation. Also, it has been shown in various studies that high use of SABA is associated with increased risk of emergency department visits, increased risk of mortality. So if you look at GINA 2019, if an individual requires more than 3 canisters of a short-acting beta agonist like salbutamol, he is at an increased risk of severe exacerbation, which would land up in hospital or require intubation, mechanical ventilation. More than 12 canisters in a year is associated with increased risk of death. And all of this is because of increased airway inflammation with regular use of short-acting beta agonist alone. So why does this happen? Why does this SABA overuse lead to these problems and exacerbations? Because what SABA does is it reduces the consequence of the exacerbation. It does not take care of the cause of exacerbation. So when a person has an exacerbation of asthma, the symptoms increase beyond the day-to-day and week-to-week variability. As the symptoms increase, the use of short-acting beta agonist increases. This increased use of short-acting beta agonist does nothing to the lung function which worsens. However, it will give some relief of symptom, but the inflammation keeps on increasing. And as the inflammation keeps on increasing, it leads to an exacerbation of asthma, which leads to the need for oral corticosteroids. And that is why it is said that SABA reduces the consequence, that is the symptoms during an exacerbation, but it does not do anything to the underlying cause. And that is why it is important to use appropriate medications. We'll come to that. And that is where the SMART strategy stems from. So what is the strategy for preventing exacerbations and treating early? Is you have to identify the high risk patients or patients who are at a risk of exacerbation, give them the adequate maintenance treatment or the controller treatment, educate them as far as what should be the reliever treatment, give them a written action plan for asthma, and provide them a safety net when the symptoms worsen. What do you mean by safety net? You should have a plan as to what the patient needs to do in case their symptoms worsen, what should be the level to which they can continue taking care of them at home, and what is the scenario in which they should seek medical advice. And that is where we come to this role of a single inhaler regimen for uncontrolled asthma, the SMART approach. What do you mean by SMART? It is the single maintenance and reliever therapy or maintenance and reliever therapy in one inhaler. Why is this beneficial? So the preferred molecule as far as the inhaled corticosteroid and the beta agonist goes is formoterol budesonide, which has been widely studied in most studies. That put into a single inhaler will have a dual impact. It will do one, bronchodilation. Second, it will control the inflammation, which is the mainstay of asthma. And once, if you treat inflammation appropriately, it will reduce the future exacerbation risk. So this strategy would be using a formoterol budesonide inhaler or a formoterol inhaled corticosteroid inhaler every morning, every evening, and as needed. Now, why formoterol budesonide? It is not because of any other reason, but because of the efficacy of these two molecules put together. Formoterol is a long-acting, however, it is a fast-acting beta agonist and gives symptom reliefs in 1 to 3 minutes. Also, the budesonide rapidly dissolves in the mucus layer of the airways in as fast as 6 minutes, leading to early response in terms of relief of symptoms when it is used as a reliever. Now, this is what is depicted in this graph. In this study, what is shown that if you use inhaled formoterol and corticosteroid as a reliever, as an immediate intervention when the symptoms worsen, over a period of time, the symptoms would come under control. However, if you're just using a short-acting beta agonist alone, then it will lead to worsening of symptoms, eventually leading to an exacerbation and a requirement for oral steroids. And that is what we are trying to prevent. We are trying to prevent an exacerbation and trying to prevent overuse or excessive use of oral corticosteroids. So this is easily depicted in this, graph here. Once you have worsening of symptoms, if you do not appropriately address it, it leads to an exacerbation, at which point of time you need oral corticosteroids and eventually leads to a recovery. However, if you use an inhaler which is having inhaled corticosteroid along with a long-acting beta agonist, it will lead to reduction in the chances of reaching the stage of exacerbation and the symptoms settle and leads to a speedy recovery. So that is why the GINA guidelines since 2020 have changed the preferred reliever to ICS formoterol low dose as compared to a short-acting beta agonist. Why is it so? It reduces the risk of severe exacerbation compared with SABA alone. Any patient at any step of the treatment can use this low-dose ICS formoterol for symptom relief, and that it is known as the SMART approach. When it should not be used, if you are using a different molecule, if you're not using formoterol and inhaled corticosteroid, then you cannot use formoterol inhaled corticosteroid low dose as a reliever therapy. The same molecule has to be used. Salmeterol, unfortunately, with an ICS cannot be used in the SMART approach because it has a ceiling dose of salmeterol, and also it is not a rapidly acting, long-acting beta agonist. So this low-dose ICS formoterol gives prompt relief of symptoms, reduces exacerbation, it causes an improvement in FEV1, and in the long run reduces the overall steroid load, be it the inhaled corticosteroid or be it the oral corticosteroids. There are multiple studies which have supported this. This study showed comparison of salmeterol fluticasone high dose versus formoterol budesonide, and it was clearly shown that there is a 33% reduction in exacerbation, 31% reduction in hospitalization, and a 58% reduction in oral corticosteroid use. Again, this study is showing the same thing. People who are on ICS LABA as a single inhaler approach or using the SMART strategy have a reduced chance of exacerbations as compared to patients who are on ICS LABA and SABA. Again, multiple studies here have shown that formoterol budesonide as a molecule used as a reliever as well as a maintenance therapy leads to a significant reduction in severe exacerbations. So again, multiple studies showing that there is almost 20 to 40% reduction in exacerbations and almost 30 to 40% reduction in a need for hospitalization with a single inhaler regimen. Also, it leads to improved symptom control over a period of 24 hours. What do you mean that improves symptom control? Means there are no daytime symptoms, there are no nighttime symptoms, there are no nighttime awakenings, and it reduces the need for an as a needed medication. So if you use this strategy, eventually you're going to have a better symptom control, and it reduces your nighttime awakenings as compared to baseline. And over a period of time, there will be a reduction in the number of days when you require a reliever. In one study, they demonstrated that in a period of 12 months, almost 60 to 65% of the days, patients did not require a reliever therapy at all. So their symptom control obviously has got better. This is the same thing which I've already told. So this makes us understand that the SMART approach to the treatment of asthma is going to, one, improve your symptom control. Second, reduce the risk of exacerbation. Third, reduce the risk of hospitalization. Fourth, have eventually reduce the mortality related to severe exacerbations. And in addition to this molecule, you also need the right inhaler. That brings us to the next part of the talk, the role of inhaler device in asthma management. So there are three factors which are important as far as providing optimal drug delivery. There are patient factors, there are device related factors, and a formulation related factors. The patient factors could be in the form of age. Extremely elderly individuals may not be able to take inhalers properly, in which case you may require nebulization. There are patients' disease condition, the patient's personal acceptance. There are a lot of patients who do not want to use an inhaler. Also, the training of the patient in using the inhaler device. So all these will impact the delivery of the drug. Also, the device will impact the delivery. So the device is extremely important. It should be able to deliver consistent dosages. It has to be easy to use. The cost of the device should not be very high. And the formulation which is there in the device has to be stable and safe. So it is the incorrect choice of inhaler or the poor technique of inhaler which is responsible for poor asthma control in majority of the individuals. So if you look at most of the patients who have poor asthma control, and if you check their technique of inhaler, it is the faulty inhaler technique which is responsible, or most of the times patient just take the inhalers as and when needed. They do not adhere to the treatment regimen, and that is responsible for the poor control of asthma. So this is what is depicted here. The poor adherence to inhalers is responsible for poor asthma control, and there are multiple factors why patients are not adherent to inhalers. They could be because of the difficulty in using the inhaler device. Also, sometimes patients are prescribed multiple inhalers in a day. They are prescribed different forms of inhalers at the same time. So all this leads to confusion and a poor adherence. Sometimes unintentionally patients are not adherent. They forget, it is not a part of their daily routine. They do not understand the instructions. All of that also can lead to it. But most of the times what we understand, it is an intentional poor adherence because of their perception or their myths about the inhalers, their denial about the diagnosis of asthma, their inappropriate expectations, the cost of treatment, concern about the side effects which are perceived by them, and a lot of stigmatization which is associated with asthma. So all of this are responsible for their poor adherence and hence a poor control of asthma. And that is why it is important for us to have a inhalation device which would be ideal. What do you mean by an ideal? One, it has to be easy to use. Second, it should consistently deliver the medication even if there is a lack of an appropriate technique. It should ensure adequate deposition of the medication at the site where it is supposed to act so as to reduce the local and systemic side effects. It should have consistent delivery of drug, and it should be easy to use and reload in case multiple actuations or multiple doses are required. In addition to having the right inhaler, it is also important to have the right particle size in the inhaler. So the optimal particle size in the inhaler is around 1 to 5 microns. Large particle size will not serve the purpose because they'll get deposited in the oropharynx. Smaller particle size are more likely to be exhaled back out, and hence they will not give you the desired asthma control. Now, if you look at the deposition with different forms of inhalers, it is the least for the dry powder inhalers or the rota caps, which we talk about, around 14%, compared to 21% for the pressurized MDI. It is better for pressurized MDI with a spacer, or it is the highest for devices like turbohaler, which has high as 38% lung deposition. Now, we know that you have to give the right device, but you also have to assess the inhaler technique of the patient. Just prescribing the right device is not enough. You should also make sure that the patient understands how to take the inhaler. You should simplify the regimen. You should try and avoid giving two different types. There's no point giving one MDI and one rota cap as a reliever. So make sure that it is a single type of inhaler which is prescribed to the patient so as to simplify the things for them. You should choose the steroid molecule wisely. You should invest appropriate time in training each patient with the appropriate inhaler technique. You should observe how they take it. You can let the patient observe how it is to be taken with the help of video demonstrations. You can teach maybe your technician or your support staff to teach them the technique, and make sure that you reassess the technique of inhaler at each outpatient visit. This goes a long way in making sure that the asthma is appropriately controlled. Now, if despite all of that and optimizing the treatment, the patient is not getting better, it's time probably to seek expert advice. When would you want to seek expert advice? One, if there is difficulty in confirming that it is asthma, suspected occupational asthma because it is difficult to treat and you have to make sure you take away the inciting agent. So somebody who has persistent or severely uncontrolled asthma despite high levels of inhaled corticosteroid, if they have any risk factor for asthma-related death, what is the risk factor for asthma-related death? Anybody who has had ICU admission and required mechanical ventilation for asthma is at an increased risk of death from asthma. Or if there is evidence of significant side effects related to the treatment and somebody who's requiring long-term oral corticosteroids, then it's time to seek expert advice. Now, just to, the brief concluding part of the talk, it is very important for us to communicate the diagnosis of asthma to the patients. Even now, asthma as a terminology carries a lot of stigma. I don't know why, but a lot of patients dread the diagnosis of asthma. They're also confused as to whether it is asthma or it's allergic bronchitis or it's seasonal bronchitis. So they're very confused about the term. So it is very essential for us to communicate very clearly that the diagnosis is asthma. They also have a lot of questions as to what is the cause, why did they get asthma, what is going to happen next to them, what is going to be the pattern of treatment, what can they do, what they cannot do, whether it's going to get cured or it's going to only get controlled. And that is why it is important to spend time with these patients to make them understand all of these things. So what is our responsibility? We have to communicate the diagnosis very clearly to the patients. There is no harm in letting them know that it is bronchial asthma. Just because the patient may not like it, labeling it as allergic bronchitis or seasonal allergies is not going to solve the problem. Once you have communicated the diagnosis, it is important to understand what is the patient preference as far as the treatment goes. You have to sit down with them and bust their myths as far as inhalers are concerned. There is still a lot of resistance to the use of inhalers. And that is because they have wrong notions. They think that inhalers are addictive. They think that once they started, they'll have to take it lifelong. And they think that they have maximum side effects. So you have to sit down and make sure that they understand that none of these are correct. You will have to educate them as far as what is going to be their treatment plan. You will have to document an action or a treatment plan from there and sit and give them time so that they build the confidence that they're going to face this easily and overcome it. Now, it would be inappropriate to end this without understanding what are the recommendations as far as COVID-19 and asthma goes. Just one slide on that. Even in the current pandemic, though it is not ended completely, it is important that we do not reduce the inhaled corticosteroids or oral corticosteroid if the patient is already taking that. If we do that, it has a potential to cause dangerous worsening of asthma. You make sure all your asthma patients have a written asthma plan. They should understand how to increase their controller, how to use relievers, when to seek medical help, and avoid nebulizers as far as possible in the inpatient setting, because there is a risk of aerosol generation and transmission of the virus. The preferred thing would be using a spacer with, MDI with spacer. So this is as far as COVID-19 and asthma goes. To summarize, asthma is a global health burden, and lots needs to be done to improve the level of control. Poor control of asthma is driven by overuse of short-acting beta agonists and underuse of inhaled corticosteroids, both of which increase the mortality risk. And that is why the one inhaler regimen or the smart approach is important to reduce the risk, frequency of exacerbation, and the need for hospitalization. This will help patients achieve well-controlled asthma and provide rapid onset of bronchodilation. So just a small take-home message, I would say, write it down, establish the right diagnosis, have an appropriate communication and education for the patient, along with the right formulation, right device, right dosage, with smart strategy. This will go a long way in managing asthma the right way. Thank you.
Thank you very much, Dr. Rohan Aurangabadwala. There are some questions from the delegates. Role of bromhexine and montelukast, role of IV aminophylline in acute exacerbations, and role of chromoglycate.
Yeah, so these are all add-on things. When patients present to your outpatient departments, if it's just a pure exacerbation of asthma, most of the times your inhaled corticosteroid bronchodilator along with an oral corticosteroid for severe exacerbation is going to suffice. If they have add-on allergic symptoms like allergic rhinitis, that is where you would want to give something like an anti-allergic montelukast levocetirizine combination. Or they have significant amount of eosinophilia, you would want to give montelukast levocetirizine. Regular use of these montelukast levocetirizine is not recommended. They can be used as add-on therapy, but they are discouraged. IV aminophylline has a lot of toxicity. Frankly speaking, it's almost out. I have not used IV aminophylline for the last 20 years myself. So I would strongly discourage the use of IV aminophylline as a modality of treatment.
What is the
So yeah, muscarinic agents can be used in the treatment of exacerbations of asthma. Short-acting muscarinic agents is what we try to prefer. Long-term, the use of the muscarinic agents in control of asthma is only at step 5, where you would want to add on a long-acting anti-muscarinic agents like tiotropium. That is when your symptoms are not getting controlled despite using a high dose of inhaled corticosteroid. Then it comes a part of the treatment regimen. But once you have achieved control, you would probably do away with the LAMA and then continue high dose corticosteroids. Once further control is established, you start reducing the dose of the inhaled corticosteroids. That is the treatment strategy.
Is there a role? Hi, Dr. Kashyap here. Hi. Is there a role in using oral theophylline these days? I mean, as far as the new guidelines are concerned?
So no, none of these theophylline are a part of any guidelines as of now. Very small subset of patients, you can use something like an acebrophylline, which has a side chain which has mucolytic activity, but that is also not needed in most of the patients if you're using the right strategy as far as inhalers are concerned. Only role of theophylline to me is in patients who have severe COPD and have the diaphragmatic weakness, because theophylline tend to increase diaphragmatic contractility. So COPD patients have a lot of flattening of the diaphragm. So that utility can be used where the diaphragmatic contractility increases and it improves the work of breathing in COPD patients. That's where I sometimes use pure form of theophylline very selectively, making sure that there is no side effects in terms of tachycardia and stuff.
Any other questions? Thank you, Dr. Rohan Aurangabad wala. It was really very informative lecture. So now we move on. There is a change in speaker. Instead of Dr. Ravi Mohanka, we have Dr. Praveen Agrawal. I'll introduce Dr. Parveen Agarwal. Dr. Parveen Agarwal is a consultant in Department of Liver Transplant and Hepatopancreatic Biliary Surgery at Sir H.N. Reliance Foundation Hospital and Research Center. Dr. Parveen Agarwal graduated from Mumbai University and completed DNB General Surgery from KJ Somaya Medical College at Sion, Mumbai, followed by DNB in Surgical Gastroenterology from Jaslok Hospital and Research Center, Mumbai. He underwent advanced training as a fellow in hepatopancreatic biliary and liver transplantation at Medanta Medicity, Gurgaon. Dr. Agarwal is trained to administer basic life support, advanced trauma life support, and is certified in basics as well as advanced laparoscopic techniques. He has several research publications and conferences papers to his credit. Over to Dr. Parveen Agarwal. Dr. Agarwal.
Good morning, everybody. Can you hear me? Can you see me?
Yes, yes, sir. Yes.
Thank you, everybody. Thank you, Dr. Kajal, for my brief introduction. I'll share my screen now. Confirm, please. Can you see my slides?
Yes, sir, we can see.
Yes.
Okay. So completely, whole slide you can see now, sir.
Yes.
Yeah, it's seen.
Okay. Now coming to today's topic, Dr. Ravi Mohanka is busy somewhere. That's why he has requested me to take this talk today. So today's talk is like surgical innovations in liver transplantation. As we know that all cirrhotic patients who are decompensated with having like high bilirubin, high creatinine, high INR, they do require liver transplantation for the protecting them from having like complications or further complications and then end organ failure, and including increasing their life expectancy and the quality of life. So coming to liver transplantation, my talk is definitely surgical innovations today. What we have done, everybody is aware about that, how the liver transplantation is, the basics of liver transplantation. And number of transplants are done now all over the world, including India. Like in India, there are around 3,000 to 4,000 transplants. Largely live donor liver transplantations are done per year in various parts of India, largely in metro cities right now. Second tier cities also started the happening the liver transplantation. Now, as we know, there are two types of liver transplantation: deceased donor liver transplantation and live donor liver transplantation. Deceased donor liver transplantation, as you know, we remove when the patient is donor is a cadaver donor who is branded on ventilator, and his liver, we take out the whole complete liver and then do transplant in a recipient. And second is a live donor liver transplantation, where any voluntary donor from the family of group match, near family or little bit distant family, we take and then we do transplantation in them. Now coming to deceased donor liver transplantation or a cadaver liver transplant, what happens before, whenever this is a leftward image showing the liver which is cirrhotic, and after transplantation, what happens? Like liver looks like this. This is an imaginary presentation to that. What we do, so I'm going to focus on the various parts in deceased donor liver transplantation. What is the innovations happening, and what is the innovations happening in live donor liver transplantation further. So what we do basically in cadaver liver transplantation, we dissect the whole abdomen of the abdomen of the cadaver. We separate the bowel, cannulate the vessels, and clamp the aorta, and then infuse that organs with the HTK solution or UW solution in that, so that whenever we remove that liver from the body, it is bloodless and it is provided the various nutrients, micronutrients, which are required for the survival of the organ once it is removed from the body. and it is packed in a plastic bottle, which is and in a cold storage, and keep it in a storage. As we know, liver can be stored for 6 to 10 hours of prolonged time in a cold storage. So once we remove a liver, we have to perform a surgery on a recipient also simultaneously. We remove recipient's complete liver, which is attached with the portal vein and hepatic veins, as we can see that. And hepatic veins in turn opens into IVC. Now, after implantation, it looks like this. We do an anastomosis, like a liver here. The anastomosis is done between IVC to IVC over here. Then suprahepatic IVC, infrahepatic IVC. Portal venous anastomosis, which is giving the 70% of blood to the liver, and hepatic artery anastomosis, which gives around 30% of the blood to the liver. The fourth anastomosis, which is we perform, is the bile duct anastomosis, which is not shown in this picture. The order of anastomosis over here, we do first hepatic venous, then portal venous, hepatic artery, and then bile duct. Now, so what is the innovation happening in cadaver liver transplantation? As we know, in cadaver, we remove the whole liver. But surgically, we have developed a technique in a cadaver who is stable. We divide the whole liver into right lobe and left lobe. This either we do in a cadaver body itself, or we remove the whole liver, or do a division of this liver into two parts in a surgical table. This, as we know, the right lobe is the 70% of the liver, and which is bigger in size, and left lobe, which is a smaller part, which is around 30% of the liver. So after removing the liver from a cadaver, we divide this liver into two halves, and this one half will go to one recipient, one half will go to other half will go to another recipient. So one liver, earlier we used to use in a same patient, only one patient. Now, by innovating this surgical technique in a cadaver, we can transplant divide the liver and transplant this half of liver into two recipients. The graft or amount of liver which we need usually depends on how much we need, is based on the recipient's weight. So this right lobe contains the 70% of the liver, the left lobe contains the 30% of the liver. So the right lobe is usually given to the adults, and the left lobe, which is after splitting, usually given to pediatric patients, where we require less amount of liver. This is the innovation. This innovation has definitely helped us in increasing the donor pool. As we know, about around 3 to 6 or 7, 8 donations per month happens in Mumbai city itself, but we have around 400 patients waiting for liver transplantation who requires urgently transplantation. This was the first city. Our Mumbai city has done the split liver transplantation and is transplanted to the patient over here. Now coming to live donor liver transplantation, the rest in the recipient cadaver, there was not much surgical innovation which has happened over a period of time. Now coming to live donor liver transplantation. The basic of live donor liver transplantation is the right lobe of the liver we remove and transplant into a recipient after removing the previous deceased liver. Now the anastomosis is definitely sees right hepatic veins, portal vein, hepatic artery, and the bile duct. So what we do in donor surgery? Donor surgery, we do the right lobe and left lobe, which is divided by the middle hepatic vein. We go in this plane and divide the liver in the center in two halves. As we see in this picture, we see the right lobe over here, the left lobe over here, and this is completely divided. And which is attached, we have inflow, but in this case, whenever we divide, we need to preserve inflow of this part of liver also, inflow of this part of liver also. Inflow means blood flow, and outflow blood to this part of liver also, and this part of liver as well. So we have, God has given the organ, though the liver is only one organ, but they have dual blood supply of right portal vein right lobe has a right portal vein, left lobe has a left portal vein, which is divided into two parts, and we divide liver into two halves from here. Then hepatic artery is also there, which is right part is supplied by right artery, left part by left artery. And the bile duct also is having the same kind of right bile duct and left duct. So we can divide liver into two halves, and then we can transplant the same as we do in deceased donor liver transplantation. First hepatic venous, and then portal venous, then hepatic artery, and the bile duct. The uniqueness of this could happen only because of the uniqueness of a liver parenchyma to regenerate to its full capacity. Because this liver, which is not sufficient for a recipient, then definitely they will require a good amount of liver, but this liver will regenerate to into 6 to 8 weeks to into full capacity. So from this one liver, how many lobes or what part of lobes we can donate to a person? As I told you, the right lobe will contain 60 to 70% of the liver. This can be done, or left lobe of a liver, which is divided between the middle hepatic vein. This can be done, or in a patient who adult to adult transplant, which we need to do. Pediatric patients where we need only small amount of liver because of their small weight and small abdominal cavity, the small amount which contains the left lateral segments, and it is 15 to 20% of whole liver. So there are three types of live donors, hepatectomies, live living donor, which we use in different part of recipients wherever appropriate, based on recipient's anatomy and based on donor anatomy and requirement of liver volume. So once we do that right hepatectomy, it looks like this. So here we can see the inflow vessels are there, hepatic artery, which is going like this. This is portal vein, and this is a bile duct, small bile duct, which we can see. Here, the right hepatic vein and the mid part of middle hepatic veins, which we can see. And this is how the cut surface of a liver looks. We reconstruct this outlook with our two vessels. This we can't anastomose to the IVC directly. So we use this extension graft to these veins, and then single opening will be attached to IVC over here. Usually the portal venous and the hepatic artery anastomosis doesn't require any extension. So as I told you, like how we implant the livers into live donor liver transplantation. First, we implant the right hepatic vein, then middle hepatic vein, portal vein, hepatic artery, and bile duct. Similarly, when we take left lobe, the left hepatic vein, left portal vein, left hepatic artery, and the bile duct is anastomosed usually to intestine, which is the loop of hepaticojejunostomy. So we will have a question like there are two types of transplants, deceased donor liver transplantation and live donor liver transplantation. So what is the difference between the two? First of all, there is definitely a waiting time which is there in deceased donor liver transplantation, that is 6 months to a year. In live donor liver transplantation, we don't require any waiting period in that. We can transplant this patient once the donor is available. We investigate the donor thoroughly, and within 2-3 days also we can perform a transplant if we have a donor. The organ quality is different between definitely DDLT and LDLT, because deceased donor liver transplantation is absolutely unpredictable quality and unpredictable time of a day or night, and it is definitely unplanned surgery. So whenever we have a call for organ, we do a transplant. We do have to do a transplant. But in case live donor liver transplantation, it is always a planned surgery. We do thorough investigation of a donor, quality of a graft, quantity of a graft. Everything can be done in a planned manner in live donor liver transplantation. So why we do DDLT is good in patients where the live donor, where the liver disease of a recipient is little bit stable, and we have a time of 6 months to a year. This period is absolutely unpredictable, and it can go to from 6 months to minimum to 18 months maximum. So we will have to keep this patient under surveillance and maintenance medication till that time. So as earlier, again, I told you the volume of liver or which part of transplant we need to do or which kind of liver we need to do is based on recipient's weight. If we have a recipient whose weight is around more than 100 kilograms, so he will definitely require a big amount of liver. So this is the deceased donor liver transplantation is best for that patient because we can transplant, take whole liver and transplant them. Another best part of, another good part of the deceased donor liver transplantation is if the recipient doesn't have any live donor in their family, or they do have the matching group or donors are not fit in their family, then the deceased donor is the only solution. The preferred patient whenever, in case of LDLT, as I told you, like within 2-3 days of transplantation, also we can perform a live donor liver transplantation in acute liver failure patients. And second is where, as you know, the indication for liver transplantation is also hepatocellular carcinomas, where we also have to do a transplantation in emergency, not in emergency, semi-emergency kind of in HCC, where we have a fear of spread of HCC outside the liver. So these two conditions where live donor liver transplantation scores over DDLT, and these are the two conditions where the DDLT scores over the LDLT. So we will have to take a decision based on each individual patient and take a decision based on whether the patient require LDLT or whether the patient require DDLT. The biggest problem of live donor liver transplantation is the donor risk. Though we have completely innovated by doing preoperative investigations of a donor, by doing CT scan, MRI, their preoperative anesthesia checkup, their cardiac evaluation, renal evaluation, pulmonary evaluation. And the risk is definitely there, but completely not, we could not remove, but definitely, yes, there is a risk, but minimal now. So another innovation is like dual transplants. So we have a patient like who are diabetic, who have a kidney disease also. And as you know, diabetes also leads to non-alcoholic fatty liver disease. So those who have kidney as well as liver disease, where transplanting one organ is not possible because of another organ. So we see here, we perform the liver donor transplantation, live donors, and kidney transplantation also. This can be done in cadaver donations, cadaver transplantation also, but live donor can be done. Here we had a patient from Malad, Mumbai, where the liver was donated by the son and the sister donated the kidney. The two donors, 3 operations simultaneously done, and dual transplantation could be performed. So this was another innovation. Another innovation, like as I told you, when patient is more than 100 kilogram, he will require a good amount of liver, but he has 1-2 donors where the one lobe is not sufficient. So we take another donor and take this left lobe, like right lobe from one donor, left lobe from another donor. So the graph which is there, 520 gram, suppose like we measure this graph like 520 gram, left lobe is 250 gram, then total is like 772 grams. And the formula or the ratio which calculate the graph recipient weight ratio, normally usually it should be more than 0.8, and earlier it was 0.5 because of the recipient's weight. Now after taking those two, the GRW came to 0.98 and we did the transplantation over here. We have to perform transplantation, like right vein will be transplanted and joined to right vein, left vein will join to left, this one recipient. And this transplant, this is another innovation, and this can be done. So this was like another innovation in like auxiliary liver transplantation, where in recipient, as I told you earlier, the whole liver is removed. But in auxiliary liver transplantation, we don't remove the complete liver, we remove the right part of the liver, the left part is remaining, native liver is remained over there. The graft, we take right lobe and we transplant over there. Similarly, we can do is like right lobe can be left behind, the left lobe can be. This is usually done in patients who have a metabolic liver disease, and this was the early patient. Another is a swab transplant. Suppose we have a live donor liver donors in a fit, medically fit, but their group is not matched. Like we have a recipient over here who is A, and the donor we have a B. We have another pair of a recipient who is B group and has a donor A. So if there we investigate them and say that they are fit, what we do, this donor will donate to this recipient, and this recipient will get liver donor from this. This is called as swab transplantation. This we do need to take a permission from DMER, and this transplant, this is 4 patients will be operated together at the same time, and we do a transplantation. This is just another we did like from the Pune. The one recipient was from Pune, another recipient was from Nairobi, and the transplantation was done. Another innovation where we, as I know that to increase the donor pool, we are doing all these things like doing swab transplant, doing auxiliary transplant. Another innovation is the ABO incompatible transplantation. Whenever we have a recipient who needs transplant, we only see about the group matching, like ABO group matching only. Positive, negative means RS typing doesn't matter in these cases. So if a patient is recipient is A group, so he can receive liver from A group or O group. Positive, negative doesn't matter. So these 2 groups he can. If they do not have this kind of donations in donors in the family, either A or O, then we need to search for another donor. But if they don't have any other donor in the family, if suppose A recipient is there and they have a B group, so what we do treat the recipient by doing IgG, plasmapheresis and rituximab, and then perform a transplant on them. So it's ABO income, like B can donate to A can donate to B. This can be done. Definitely, this is like cost is more in this case because the treatment of recipient, and definitely some 5% chance of increased risk of infection in these patients. Rejection of this patient are equal that once they once they cross around 5 months, 6 months, they're equally like without EBO incompatible donor. Now coming to these were the innovations in recipient surgeries. Now what have we done for donor evaluation, donor surgical innovations? As we know earlier, whenever we do open surgery, donor surgery, laparoscopically as well as robotically can be done now. Earlier, the incision we used to take for donor liver surgery was Mercedes-Benz, like right side extension, left side extension, and the central midline extension. Then it is came modified to hockey stick incision, and now few people are including where patients are thin, we take midline incision, and another is like a robotic and laparoscopic donor surgery where we won't take upper body incision. We can see the port positions over here, and we retrieve the liver from the fenestrial incision. So this incision will be definitely cosmetically better. It will heal early and will not have any complication in future life. And these are like midline incision and laparoscopic are no muscle cutting. The patient will have less pain, shorter hospital stay, and faster recovery and back to work. This was the innovation in laparoscopic surgery. I told you like donor hepatectomies are now performed, which is more precise than laparoscopic surgery because they have a 3D view, 7 degrees of freedom of a movement, and the tremor filtration is definitely better in laparoscopic donor hepatectomy. Now, another innovation of organ like cadaver organs is a drone. We must have read in a newspaper like our food deliveries are happening through drones. Drone fans increasing in size innovations. Similarly, organs, if suppose wants to come from Pune to Mumbai, it's like around at most take around 2 to 3 hours. If we create a green corridor, if otherwise because traffic congestion is there, to nullify that, drones are coming like from one target point. If it is feed from them to the other target point, that can be transported in no time. This is definitely under investigation, but yes, it will come within 2-3 years or 4 years. It will come to India for sure. So the last innovation which is there in transplant is a xenotransplantation. Must have read about the pig transplantation in Spain for heart. And recipient could survive for 1.5 to 3 months. And now it's definitely the recipient died, but not a surgical complication, definitely not a immunosuppression related complication, not a rejection of organ, but some xenovirus infection from the xenotransplantation. This is definitely under investigation, and it will come into our future definitely. Yeah. So this was my end of slide, and definitely.
Thank you very much, Dr. Praveen Agarwal. A very wonderful lecture on transplant. Any questions from the panelists? Thank you very much, Doctor.
Yeah.
Now, we move on to the next speaker for today. Any questions from panelists? No? Okay. The next speaker is Dr. Jatin Kothari, and I request Dr. Kashyap Dakshini, Assistant Secretary, IMA CGP, Mumbai Sub-Faculty, to please introduce Dr. Jatin Kothari.
Good afternoon, friends. Dr. Jatin Kothari is Director of Nephrology and Chief Consultant of Renal Transplant Medicine at Nanavati Max Super Specialty Hospital. He is the Director of Apex Kidney Care as well. Dr. Kothari completed his MBBS, MD, and DM in nephrology from GS Medical College and KEM Hospital, Mumbai, being a university topper with distinction and honors in all these exams. Dr. Kothari did his fellowship in nephrology in renal transplantation from the University of Toronto. He received a Roche Preceptorship Award 2006 for visiting scholarship, University of Alabama, Birmingham, US, and International Transplant Observership at the Massachusetts General Hospital, Boston, US in 2009. He received the International Society of Peritoneal Dialysis Scholarship Award for training the University of Missouri Health Sciences, Columbia, US. Dr. Kothari also has several national and international publications to his credit. Today, he will be speaking on kidney paired donation exchange.
Sir, please unmute. Yeah.
Please unmute yourself. Dr. Kothari, please unmute yourself.
Sir, check your mic setting once, because even on unmute, you are not audible. Sir, go to audio settings. You can find that just beside the mute button. In that audio setting, you will see the microphone, and just beside that, there will be options to choose microphone from. So you need to select one.
Dr. Kothari, are you there?
Yeah, he's there. He's trying. His audio is not heard. No. Maybe he can use a earphone or something.
You just need to select proper mic from the audio settings. That will be it actually. But sir, can you please do one thing? You can rejoin. You can end the meeting and rejoin once again. Let's try that.
So now you unmute. They're showing you connecting to audio. So do you have an earphone or something? You can try with that.
Mobile.
Can you hear me now?
Yes.
Yes.
What I can do is, can somebody show my slides? I had sent the presentation. So,
Aditya, can you just take the slides with you?
No, sir, sorry, but I don't have any slides.
should I send my presentation to somebody?
Sir, you have connected from two devices at the same location. That's why there is an echo. So
Yeah,
you have to
I've
mute.
disconnected from my cell phone, from my
Okay.
laptop.
Okay.
So my presentation, I have sent it to. Can I forward it to you?
Sir, you can do one thing. You can connect from your laptop, but just make sure that your laptop is on mute, totally mute, and the mic is off. And then you can share the presentation from your laptop, and the audio we will hear from your phone.
Okay.
Yes, that can be done, right?
Sorry for all this, but. Can you allow me to share my slides from the
Yes, sir.
laptop?
Yes, sir. Yeah, you share it from the laptop.
No, it was allowing me earlier, but currently it's not allowing me.
It should allow you, sir. The sharing is open.
Yes.
Are my slides seen?
Yes.
Yes, sir. Yes.
Sorry for all the mess. Thank you very much, IMA Mumbai, for inviting me for something which is very close to my heart. And it's World Asthma Day, so I should say something that's very close to my lungs too. Just as an introduction, I have no disclosures for this particular talk. I also thank Sanofi who invited me to be a part of this IME conference. Swap transplant is something which I think Praveen also introduced. As far as the liver transplant goes, the liver transplant, swap transplants are also happening all across India. But something that was pioneered across the world by kidney swap transplants. And I will share with you in the next 10 to 15 minutes about our experience of having done swap transplants in Mumbai. I'm a part of the group, the Apex group, which established the Apex Swap Transplant Registry all across Maharashtra in the year 2011. We all know that the CKD population is increasing every day, and more patients are going on dialysis and require a kidney to get away from dialysis. If you look at the national figures, less than 2% of patients who have chronic kidney disease stage 5 eventually end up getting a transplant. So the availability of donors is a big problem where patients are not able to have access to transplantation because of non-matching and because of non-viable donors. We know that living donor transplant is the main form of kidney transplantation all across India, and there are more and more states which are engaging with the Cadaver transplant program also. And all across India, on an average, we do about 7,000 to 7,500 transplants every year. Some patients who have a compatible blood group straight away go for a living donor transplant when their blood groups are compatible between the donor and the recipient. But unfortunately, about 10% of patients who even have a compatible donor in their house or in their family do not undergo a transplant because the blood group is non-compatible. And that's where swap transplant comes into the picture. A subset of these patients can easily undergo a swap exchange, which is nothing but exchanging the donor kidneys to the compatible recipients in that particular pair. This is our overall experience over the last 10 years, what we have accumulated from the swap registry, which is established in Mumbai. Currently, we enrolled more than 600 patients who were a part of the swap transplant registry for 10 years. And the reasons why these patients registered into the swap registry were as follows. The number one cause and the most important is obviously blood group incompatibility, which is very simple for all of us to understand. If a donor is A and a recipient is B, obviously that transplant can be done with the current ABO incompatible results in Mumbai. But the cost is a big factor for transplantation. And that's where we as a group encourage more of swap transplants where compatible donor and recipients can undergo the surgery and the results are as good as a compatible donor from the family. The other reasons as to why the patients registered in the swap registry were as follows. They could have a HLA mismatch and a cross-match test, which is positive. And in conditions where cross-match test is positive between the donor and recipient, usually the transplant is associated with very poor outcomes. So in these pairs also, they can register for the swap and they can actually get a more compatible match and have a successful transplant. Across the world, there is also swap transplants for patients who are and donors who are Hep B and Hep C, positive and negative. And that could also be a reason why patient can register into the swap registry. And again, in India, this is probably not allowed, but in developed countries, you can have altruistic donation where somebody who wants to donate their kidney can donate to a complete stranger. And this goes through the government channels and the transplant can be done. So when we established this registry in 2011, we had patients from all across the city and even extending to all parts of Maharashtra where they registered into the swap registry. We developed an in-house software which looked at a very simple scoring system based on various criteria of the recipient. It would be recipient age, whether a recipient has had a previous kidney transplant already, how long he has been on dialysis, is dialysis difficult with a difficult vascular access? If he's had multiple vascular access failures, then obviously he cannot sustain on dialysis, and that's where the requirement of a transplant is urgent. So the priority was given to weigh all these factors and some other factors which helped every patient to get a score in the registry. And as high the score, the more higher the score, the more likelihood that he would get a swap donor from the registry. The entire transplant workup of the donor and recipient is done by the respective nephrologist who refers the patient to the swap registry. We as a group do not take over these patients. The patients are managed by the same nephrologist and the transplant surgeon at their respective hospitals, and the complete medical and legal suitability of the transplant is established by that particular hospital and nephrologist. We just do the matchmaking when they are registered in the swap registry. We give them a compatible pair, and thankfully within 6 months of time, almost 20% of the patients who were registered with the swap registry could get a swap donor from the registry. So there is still a long way to go, because we need more and more pairs to register. The more the number of patients registered in the swap, the more likelihood that these patients will get a better and better kidney. But this software did help a significant number of patients who would otherwise have not had a transplant. So as I said earlier, close to 600 patients have been registered with our registry, which is in Chembur, Mumbai. And these were the reasons as to why they registered with the registry. As of now, we have done 73 swap transplants. Some of you might be aware that we have done 2 domino transplants, which is nothing but an extended swap where more than 3 patients are actually lined up, in a domino arrangement where, you can see in this schematic diagram that this can be simultaneously performed at various hospitals all across the state and even the country, where one person's donor gives to another recipient and vice versa. And this entire chain can be built where simultaneous transplants can be done. Vivek Kute from Ahmedabad has also done sequential domino transplants after we did the first Asian domino transplant in 2013. When I say the word sequential, it means that the transplants can be done at different timelines also. That sometimes can become a problem in the private setup, because if, say, for example, the donor who is supposed to be operated next week in a sequential arrangement backs off, then the whole problem of how the swap can be carried out can happen. And that's where we encourage most of the transplants to be done at multiple hospitals, but at the same time and the same day. This was our second swap, which we then subsequently in 2014, where we had 6 pairs lined up, all in a domino arrangement. And these transplants were, as you can see, done simultaneously at Bombay Hospital, Hiranandani Hospital, and Hinduja Hospital. So in conclusion, ladies and gentlemen, the swap transplant is one way in which we can increase the donor pool and have more people have a compatible kidney transplant with good outcomes. There is definitely a need to educate patients who are suffering from chronic kidney disease. Also, there is a need to educate the statutory authorities in terms of swap becoming legal. The Human Organ Transplantation Act underwent a big change in 2014, where swap became a part of the legal transplant activity in India. And there is also a big need of educating nephrologists and physicians about this option, which can help a certain percentage of patients who are waiting for a kidney to get a feasible and a viable kidney for long-term survival. Thank you very much for your kind attention, and I would be happy to take any questions or comments. Thank you. And
thank you, Doctor. Any questions from the panelists?
I have one question.
Please go ahead. Please go ahead.
Yeah, thank you very much. Recently, we had seen in 2-3 days ago, there is a Ruby Hall Clinic kidney transplant related issues. So my question is that how, if I am one of the part of the chain from the whole process, how I can protect myself, or how I should be vigilant so not to indulge in such kind of the legal entity.
Got your question, sir. Right now, what we are seeing in the media, and this has probably happened for the swap transplant for the first time ever. This is very, very unfortunate. And if you have been able to read through the entire document as to what the problem was with the authorization committee which gave permission, and somebody who is not related actually was shown as a relative, and that's how the swap transplant was carried out. Unfortunately, as doctors and as practicing physicians, we do not have the capacity to verify as to some person whether he is a related donor or not. Yes, he comes to my clinic, he comes with a particular person, mentions to me that he is his wife, his brother, sister. We do verify initially by doing an HLA testing. Of course, genetically related donors, we will be able to test by doing a HLA test and establish the relationship. But if somebody comes forward as a wife, at least as a medical practitioner, we have no ability to verify whether this person are husband and wife. The entire onus, ideally, as per the Human Organ Transplantation Act, is with the authorization committee. They are the people who are responsible for establishing the relationship, establishing that there is no monetary transaction between the donor and the recipient. We as physicians and nephrologists and surgeons are there to manage their clinical problems. Coming to your specific point, how we can protect ourselves, I think as a community, as a medical community, we have to be very clear in terms of what our role is in the transplantation. Unfortunately, currently, the way the Human Organs Transplantation Act is in India, all the vicarious responsibility goes on the hospital and the doctors who are doing the transplant. And this is very, very unfortunate. Nowhere else in the world is this sort of a system prevalent. Unfortunately, because of some scams and some rackets which have been there in India for the last 30 years, all the genuine transplant work that is happening all across the country gets diluted, and the media takes great pleasure in terms of highlighting all these things, which negates all the positive impact that we are trying to create. So unfortunately, we have no current answer to, I don't have any current clear answer or a solution to your question, but at some point in time, I'm hopeful that we as the medical fraternity will have a clear role where only the medical part is supposed to be taken care of us and not the legal aspects and not establishing identity of the donor and the recipient and their relationship. Thank you.
Thank you very much, Doctor. Any other questions? Okay. Now
Thank you, madam. Thank you.
Okay. We move on to the next speaker, Dr. Rahul Sheth. I'll invite member IMA CGP, Dr. Komal Jatania, to introduce the speaker.
Thank you, Dr. Kazi. Dr. Rahul Sheth is a senior consultant interventional radiologist at Sir H.M. Reliance Foundation Hospital and Research Center. He is an honorary consultant in interventional radiology at various hospitals in Mumbai, like Breach Candy, Saifi, Global, Lilavati, Fortis, Prince Ali Khan, to name a few. He received his super specialty training in fenestrated aortic stent graft from King's Hospital, Melbourne, Australia. He is also the proctor for Zenith endovascular stent graft in India and Southeast Asia. His clinical interest lies primarily in aneurysm, peripheral vascular diseases, and interventional oncology. He has been the faculty in national and international vascular and interventional radiology meetings. He has published numerous articles in indexed international journals. Today, he will be talking to us on diabetic foot practical tips. Welcome, Dr. Rahul Sheth.
Thank you, Dr. Komal, for this kind introduction. So I'm going to talk on an interesting topic which is very prevalent in our country. Very ignored. Yeah. So it's on diabetic foot. I think you can see my slides.
Yes.
Yes.
Yeah. So this is what we see regularly in the feet in our practice right now. And that's a very sad thing. This is what we call a foot attack. You can see these variously infected, gangrenous, ulcerated feet, which come sadly very late still, although it's improving the situation. But we have things like heart attack, stroke, but there's nothing like a foot attack. And that's what we are trying to develop this word called the foot attack. It has to be addressed and has to be taken care of immediately. And why is it so important? You can see with this slide that nearly every 20 seconds a limb is lost due to diabetes, and which is so many times much more than due to landmines. And this is what the treatment was of diabetic foot treatment in the early 19th century. And sadly to say, even in the early 20th century, this used to be practiced. Basically just amputate the leg out and hope for good healing. But that's not what exactly it does entail. So diabetic foot is not uncommon. It's extremely common. It's a complicated treatment, and sadly, it's a costly treatment also, which is there. So we just tell you what it can happen is that diabetes mellitus patients to spend nearly 10% of their yearly income on treatment, and a diabetic foot infection can go greater than 50%. Because imagine you cannot walk. If you cannot walk, you cannot go to your job, you have infections, you keep on going to the hospital, repeated debridement, repeated treatment, and that keeps on adding to your morbidity and lack of mobility, which affects your earnings. So one part of diabetic foot infections is basically severe limb ischemia, which is defined as the presence of tissue loss. Nearly 40% of extremities with non-healing ulcers will rest pain or gangrenous digits will require major amputation. And that's a big, big number. So the main concern here is let's salvage as many limbs as possible. And where it is an ischemic ulcer, percutaneous revascularization makes a very, very big role. And it actually helps in reducing the level of amputation, sometimes avoiding amputation, and we can get the patients to get back to normal activity. So what is the basic principles of management of diabetic foot ulcers? So one, you need to assess, it's two components, mainly two components, the neuropathic component and the vascular component. Not every foot will have only, will have both. Some will have only one, some will have only the ischemic part, some will have both a combination of two, and each has to be addressed separately. And then finally, once you treat each one, then you address the whole foot as a whole, and you can try and salvage as many feet as possible. So you have to assess the altered biomechanics, the neuropathy component of the foot. Most important and the most ignored part of any examination in any clinic, I'm talking wherever the patient enters, how many of us actually take the patient on table, look at the, to palpate the dorsalis pedis of the posterior tibial of the femorals. I don't think any of us, majority of us, when the patient comes to the clinic, can ask them to take out the shoes. So if you do not ask them to take out the shoes, how are you going to see what their feet look like? And when they walk into your clinic also, you should assess how they're walking, what gait they're having, and assess those things so you'll realize if you can even pick up sometimes foot issues once they walk into your clinic. Once you assess the peripheral, if you feel there is no pulse, at least you know you're dealing with a peripheral vascular disease. Then you have to look at it from managing the foot ulcer is when you treat that, the debridement and wound care, and most importantly is the footwear management and strategies for secondary prevention. And this is what we are going to be looking at in this talk for the next 10 minutes. Now, diabetic foot, a lot of patients come to us and they say, doctor, I have this very small ulcer on my third toe or my second toe, and it looks very small. But this is a picture which we are showing you. I work in a team with Dr. Arun Bal and Dr. Sanjay Vaidya, who are the pioneers of diabetic foot treatment. And look at this, what they gave me this picture, and look at this small ulcer on the third toe, as you can see here. But when they actually made a cut there to remove it, they realized this is where the infection had spread through all the way in the plantar aspect and how deep it had gone. So it's actually like an iceberg. You see what you feel on top is just a very small thing, but actually it has gone deep inside. And this is what we need to educate our patients and tell them that it's maybe looking very innocuous to you when you come, but actually when you make a small cut and you realize how deep it has gone, this is the level of infection can spread without even the patient knowing. And one of the things I have seen, actually, even I was guilty of it around 10, 15 years back before I got into diabetic foot. We used to always do an angioplasty and tell the patients walk as much as possible as you can, which is good when you're non-diabetic. But when you're a diabetic patient, actually, you should not ask them to walk for very, very long distances and try and make them walk barefoot, especially a lot of people walk barefoot. Repeated walking is actually putting a lot of pressure on your leg. And this is what it can do. Some people are recommended these acupressure footwear, and look at the pressure injuries it can cause. It can leave these marks. Remember, diabetic patients, and especially severely diabetic patients, have neuropathy. They have the loss of sensation leads to them not realizing they're getting pain. And when they don't get pain, they feel they can walk. And finally, this can lead to these pressure marks and calluses caused by the pressure like you see in this picture. The myth: amputations from diabetic foot infections are inevitable. That's one of the myths which is there, that when you get a diabetic foot infection, everybody feels finally you're going to get amputated. The other myth is when you do an angiography, angioplasty, oh, it's just you're doing the tibial plasty, doctor is not going to last for too long, so why should we do it anyway? And that's what the myths we need to clear. Early, aggressive, empirical and treatment and targeted antibiotic treatment with the right footwear, with the right strategies, can save toes and, more importantly, save limbs, and we can get this population to be safe and walking as much as they can. Like I said, when you enter the clinic, all we need are sensible hands and eyes. You do not need fancy equipment. You do not need fancy technology. Look at the feet. If you look at the feet, you will see so many things. You'll see the color. You will see when the patient comes to you, the color of the feet. If you see that any ischemia is there, if you see that any calluses which are present, you'll see where the foot, if there's the gait is different, when the patient's walking, if there are any signs of foot drop, if you can see any heel injuries, all those things you can notice on the foot. If you see shiny skin, and if you touch the skin, sometimes there's a severe redness and tenderness, all that can be examined if you just simply look at the feet. Obviously, history taking is very important, duration of diabetes, what type of medications, hypertension. Wean out the history from the patients, ask them if they're smoking. All this adds to the problems which are there. The nature of the injury. So the most important question you need to ask your patient: how did this injury occur? Majority of them are very, very small injuries which you don't even think of. And then maybe walking barefoot in the house, some small nail has hit the patient or stubbed their toe sharply on something. The most common injury is they cut their toenails too deep. Some patients see calluses and take blades and cut that callus out, and that starts the whole sequence of events which is there. Like I said, pedal pulse examination and local site I've already told you. And this is what you need to look at. What I told you is dryness, turgid veins, nails, redness of skin, web spaces, calluses and corns, all this which you can see here, you need to examine. And from there, you can pick up your diagnosis and realize whether it's a neuropathic foot, there's a vascular foot, or it's a combination of a neuropathy or a vasculopathy together. All this is very simple to check. We have learned this when we were students. Simple gaits. We are not going to be replacing a neurologist here, but you can make out that if the patient has a neuropathy, it's a high stamping gait. The slipper can slip out, so you know that there is sensory neuropathy. Foot drops when there is foot scraping on the floor, and ulcer without limb. That's actually very, very dangerous. That if there is an ulcer and the patient is walking very easily, that means the patient has got a severe neuropathy, and that is going to cause severe damage to the feet, and we have to be careful. A little busy slide here, but if anybody wants, you can always share it to you. This is what you can ask, a 3-minute examination, and this is what you need to ask how the patients are. And it just takes this much time when you're doing for a foot examination. Investigations, which I'm asked commonly with the basic investigations, we all know that. CBC, renal profile, sugar, HbA1c, see how the sugars are controlled. I'm always asked when I'm doing an angiography that, doctor, while you're doing an angiography, why don't we also do a coronary angiography? Well, that's one of the most dangerous things to do, because remember, a majority of these patients are also got borderline creatinine, their heart functions are borderline 35 to 40% EF, sometimes 45% EF. And if the patient right now has come to you for a foot problem, unless the patient has got symptoms relating to a cardiac issue, that's the only time we mix an angio, coronary angio. Otherwise, we always take a fitness. We see that the 2D echo and all that is done. And if everything is okay, we go ahead. We only reserve coronary angiographies for patients who are actually symptomatic. These are some devices which can be there. The one which I'm pointing out to here is which shows the ankle. You can measure the pulse which is there. You can measure the signal in the leg. It's a very simple device. We use that to see the quality of the flow in the feet. There are various other devices. We don't need them. As I said, it's mainly used when we're in diabetic foot, high-end diabetic foot center, which we have in few places in our city. Imaging modalities. Now, I have seen patients coming with Dopplers, CTs, MRI also. So I think there's too many imaging which is being done. For everyone out here, the basic thing is that the most important is your clinical examination. You can pick up whether the patient has a peripheral vascular disease there. Send for a Doppler immediately. The Doppler will tell us what the problem is. And I would reserve a CT angio or an MR angio only and only if we have a dilemma of diagnosis, like we cannot feel any of the pulses in the femoral also. So that means we're dealing with an aortic problem. And if the creatinine is normal, if there's not too much calcium, we can do a CT or sometimes an MR angio if the creatinine is borderline and there is calcium, just to tell you what the level of block is. But 95 to 98% of my cases, we do a thorough clinical examination. And if you suspect peripheral vascular disease or an arterial problem, color Doppler, and we directly go to the peripheral angiography or the DSA and plan for the treatment which is there. Treatment options, I'm not going to go too much in detail. The standard, all of you know about this. The same one which I used in cardiac, we also use here is Ecosprin and Clopidogrel. Only one thing I'll say, the Trental and Complamina, which is given routinely, frankly, are more like placebos, at least what we feel. They don't have too much effect. And in high-end diabetic centers, Trental and Complamina is rarely given. Revascularization, surgery, which used to be the frontline treatment around 30, 40 years back, now is actually getting slowly replaced by endovascular treatment, where the results actually match surgery and in some cases are even better than surgery. The recovery is faster and we can open up many more vessels than what was possible when you're just doing a surgery. But once in a while, sometimes you do require to take the help of a cardiac or a vascular surgeon to help us clear some large clots. But even then now, endovascular now in, I would say, more than 99% of cases, endovascular is the main form of treatment. A simple chart, I won't spend much time on it, stage 1 to 4, and it's basically stage 4 is what we want to all avoid, is basically gangrene and limb amputation. And once we reach non-healing ulcers, the main thing what we want to do is limb salvage. We want to save as many limbs as possible. To show you a few cases, this is one of the few places where the femoral pulses were not palpable. This patient has severe claudication. Hence, we got a CT scan done, which helped show an aortoiliac block. What we have done here, earlier the treatment used to be just a aorto bifemoral bypass. Now that's completely abandoned. We may majority go in for an angioplasty or a stenting. We've gone in, opened up the artery here, and we put 2 stents and got complete flow, as you can see in the slide, which I'm pointing out to. Excellent recanalization is there. Another case, an 88-year-old man, non-healing ulcer on the great toe. Around 6 years back, when technology still wasn't advanced, our skills were still not as good as what they are now. In another hospital, someone had tried an endovascular stenting, was not possible. Hence, they did a FEMPOP bypass. The ulcer healed, but then developed another ulcer after 6 years. On the same leg, he had a fracture neck femur in between, so a redo FEMPOP bypass was not possible. And the only was considered, but it was a high risk because of his age and multiple surgeries. So someone referred it to us, and here's what we did. With technology and our skills improving, the graft has got completely blocked, as you can see. We went through the native vessel all the way down because of better wires, better skills, better technology, which we have. We have these devices where we can cut out the plaque and remove the plaque. We've gone in and opened up it. We cut that plaque out, put in stents, and revascularized the entire SFA, as you can see here. Now we've got excellent stents. There are some companies even coming out with drug-eluting stents in the SFA, and we are waiting the long-term results of this, which is pretty encouraging. So maybe we can get good long-term quality results also, maybe 15, 20 years, and that would eliminate the need of bypass completely. Another case is a 67-year-old man, hypertension with hyperlipidemia. What I'm trying to show you is what we are doing is a case like this. Debridement showed no vascularity. Means in this case, the person who, the patient who went to initially didn't even bother to check the pulse and immediately went and debrided the wound. It showed no healing. Then they examined the pulses and then they realized that it showed iliac disease. And this showed this complete occlusion in the iliac artery across the joint. Earlier would require a bypass. Now we have stents which we can put even across the joint, extremely flexible stents, designed for being across the joints and designed for extremely calcific arteries. Here, another case, popliteal disease, non-healing ulcer on the right foot, as you can see here, with the popliteal stenosis across the knee joint, no flow going all the way down into dorsalis pedis artery. 15 years back, we would not even think of going down to this level. Nowadays, we go all the way down into the foot, all the way down even into the arch vessels which come here and open up the artery. Now, majority of the times below the knee, we do not require stents. Although there are focal lesions, we can use coronary stents also there. And a lot of times I get asked this question, but doctor, you're only using a balloon, it can occlude again. Exactly, that's what it will occlude within 6 months to a year, but we are not concerned about that because we want the flow to get restored to the foot so the foot heals. If you do an angiography of the other leg, which has no ulcer, sometimes the circulation is even worse than the artery, than the leg which has the ulcer. So it's basically to keep the leg intact, to keep the leg alive, and hence we do this for mainly wound healing. When we go above the knee and for claudication, we require long-term results, hence the use of stents and hence the improved technology which is there. In this case, this patient had a disease across the joint. We ballooned it. You can see a bad dissection, and that's where we have used these new generation across the knee joint stents. Similarly, a patient here, small injury to the toe in the door, dusky forefoot, tibial disease like this. We have just used balloons, as you can see, long balloons. Now we even have drug-eluting long balloons for the tibial vessels. We go in and open it up all the way down to the foot. Now that's when we get the vascular component opened up completely. All the blocks from the aorta to the feet, we can completely open up. Medical therapy, debridement, dressing, pain control patients. This is how the whole thing goes. Get the blood vessel opened up, keep the antibiotics going on, debridement as and when necessary, dressing as and when necessary. It has to be done regularly depending on what the foot looks like. Pain control and a lot of patients. Ulcer healing can take between 14 to 40 days, can even be longer. And we have to explain that to the patient. It's not a magic pill. Do it today, the angioplasty, by tomorrow, the ulcer will heal. And that is just one step, getting the artery open. Debridement is the next step. Local debridement before revascularization is only and only done if the wound is infected. If you feel there's a peripheral vascular disease and the wound is not severely infected, the counts are not high, the patient is not having high-grade fever, then then you have to revascularize, then do the debridement. A lot of times we do the debridement. Some people say we'll wait for 72 hours, maybe wait for a week to 10 days. No, that's not the way we would like to do it unless there is some medical condition precluding that. Otherwise, we do the angiography on one day, maximum within 48 hours, earlier the better. Preferably the next day we do the debridement and clean off the wound completely. Maximum we can wait is 48 hours or 72 hours. We do not like to wait longer for that. Collaterals will not develop over a period of time if you do a plasty. In fact, the best time is to do the debridement when the flow is the best and it's a straight inline flow which we want. And most important is this. I have seen a lot of patients who go to people who are not conversant with diabetic foot, and they do the debridement, and then they tell the patients that now you can walk. No, offloading is most important till the wound heals. A few agents which do not help in healing, actually delay the healing, is the most common one which we use, cleaning wounds. We have seen people using hydrogen peroxide, use salt, povidone, iodine, chlorhexidine. All these actually delay healing and should not be used. How do you do a dressing? These slides are shared to me by Dr. Bal and he's given me permission to talk about them. Is basically irrigate with sterile saline, use post-op paraffin gauze. If there's too much exudate, you can do the dressing. You need to maybe do it every day, but if there's not much, you can do it alternate day or once in 3 days. And affordable things help us to get this wound, which was like this. We did the revascularization. Look at the lovely bleeding which occurs here. And then in the same sitting, we can close the wound. And this patient may have lost 4 toes, but would have otherwise required a below knee amputation with the level of blocks which were there. And now the wound is completely healed. It's a biomechanical problem. Please remember, no amount of vascularization, antibiotic dressing will help to heal the ulcer if you do not reduce the pressure. So offloading of the foot is the gold standard and cornerstone of diabetic foot ulcer management. Sometimes patients do not need to walk even for 3 weeks. Yes, that's a problem, but that is the one which will help the foot to heal completely. And footwear is the most common one, where we need to offload the patients. We need a pedograph to measure the plantar pressure. And you can see standard shoes do not help. Custom molded shoes help to reduce the pressure on the legs. And that's what we need to give our patients, is custom designed footwear. We measure the pressure highest, maybe sometimes the pressure can be highest on the forefoot, sometimes the pressure can be highest on the heel. Where we need to give more padding, all that can be done. What are the methods of offloading? Bed rest is the most important one. If they need to walk, a crutch or a walker walk, total contact cast, modified footwear, all these things are available in the specialized centers which we have, and we should get those. The way when you have partial or toe amputation, or partial foot amputation, there are special insoles which are designed for these patients and should be given to them, so that aids the healing even when they are in the house and when they have. So you can see this, a patient who's got, let's say, an ulcer on this leg, on the right leg, let's say, needs to walk. You can have these cost-effective practical offloading device where you can walk with this and keep your complete pressure off this leg on the foot, which is there. So these are what are the things we know. As you can see, all these offloading foams, special footwear, which is available. And this was our data, which was there around 18 years back, where we would salvage around 68% of our, 68 to 70% of our patients. And now in 2022, yes, getting a limb salvage rate of close to 90 to 92%. And that's how we have evolved in our technology. In 2015, as I said, 83%, and now at 2022, we have reached to 90 to 91%. And that is why the reason we're doing this is marked improved in diagnosis, marked improved in picking up where patients have a vascular block. The way we can open up vessels now is unparalleled to what we were doing around 20 years back, where we would just open up the SFA and hope for collaterals to form. Now we go all the way to the distal foot arch, and as much blood flow we can for our diabetic foot surgeons. The way they manage the foot is literally like the way managing a small baby. You have to take care of the foot care, debridement, foot mapping with shoes, and that's how we have helped. And that is what we want to start. Other than coronary care units, stroke units, we need a foot care concept where time is tissue. And this is where the whole team comes into play: an intervention radiologist, a diabetic foot surgeon, diabetologist, podiatrist, and obviously the primary physicians who are seeing these patients daily, the general physicians, the medical, the surgical, all of us form a team to help to save as many legs as we can. Before I end, if anybody wants, this is one of the 10 commandments of foot care. Do not walk barefoot. Do not play special massages, deep massages. Do not apply hot fomentation or cold pack, strong ointments on the leg. A lot of us feel, oh, we have some pain, diabetic foot pain, we'll put a cold pack or we put a hot fomentation. Remember, diabetic neuropathy will not let us know the temperature. Inspect the feet daily, cut your toenails, trim square, never remove your footwear, clean the feet with just soap and water, wipe the web spaces and keep them clean. Never cut the corn and calluses, as I said. And these are our feet crying out, please save me, please. And that's what we need to do. Thank you so much.
Thank you, doctor, for the nice presentation. Okay, any questions from the panelists? Dr. Pashnikar, you can unmute and... Dr. Pashnikar, say something. You want to speak?
Yeah, and Dr. Anil Pashnikar over here. The great that IMA Mumbai branch has organized the asthma webinar on the, this is the perfect occasion that the World Asthma Day gets celebrated on the second Tuesday of the May. And regarding this, IMA Mumbai branch is always on the forefront to organize to celebrate the World Asthma Day. And we celebrate this in a very unique way. That means the thing is that here we conduct the public awareness program. I am a Mumbai branch doctors for the people of Dharavi. And here we goes in the people, around 1,200 people get over there. And then we explain them what is the asthma, how you will come to know that you are suffering from the asthma, what are the causative factors of the asthma, at the same time, what kind of investigation you do for the asthma, what kind of line of treatment is there for you to the asthma, at the same time, being asthmatic, how to live a hearty and healthy life and all. You are seeing this, our president is also talking in front of them, all this mob crowd, our secretary Dr. Girish Lad, all of my team, myself Dr. Anil Pashnekar, Dr. H.S. Shingan, senior leader, and Dr. Sanjeev Khosla, all IMA doctors. We call all the corporators of the local areas, we call all the police personals of the local areas, MLA, MPs, so that the people also come to know, politicians also come to know, police department also come to know that Indian Medical Association doctors are always on the road to help the poor downtrodden peoples. And then we involved a company like Cipla and all, which they give the free of charge medicines, pamphlets, informations to the needy peoples and all, and to the chronic peoples and all, so that everyone get benefited out of such a noble job done by the Indian Medical Association. Here, I really appreciate all the doctors came. They updated all the doctors about the asthma, consequences of the asthma, diabetic food, and everything. So I'm really happy such kind of program is getting conducted under the leadership of President Dr. Anil Awad, Secretary Dr. Girish Lad, and Assistant Director of CGP, Dr. Kajal Ahuja. So, friends, thank you very much for giving me time, and I had a nice talk with all of you. Thanks a lot. Thank you very much.
Yeah.
Thank you very much.
Friends, he was Dr. Anil Pashnekar, Chairman of the World Asthma Day, talking to us. Over to Dr. Kajal.
Okay, now we come to the end of the webinar. Our last speaker, Dr. Kiran Kolo, she's there. I'll request Honorary Joint Secretary Dr. Arvind Patel to kindly introduce Dr. Kiran.
अरविंद आवाज नहीं आ रही है. Arvind, we cannot hear you.
Dr. Anil, you can ask someone else. You can ask someone else to introduce her.
Yeah. Okay.
I'll introduce.
Yeah.
Dr. Kiran Kolo is the head of Department of Obstetrics and Gynecology at Leelavati Hospital and Research Center, Hinduja Healthcare Surgical, Khar, and Honorary Senior Consultant at Holy Family Hospital. She has received 2 gold medals for standing first in the university in obstetrics and gynecology at the final MBBS exam. She has done fellowship in assisted reproductive technology and minimally invasive surgery at Baylor College of Medicine, Houston, Texas, USA. She has over 30 years of teaching experience and is currently a DNB teacher. She is practicing minimally invasive surgery since 1994 and has trained more than 500 gynecologists in gynec endoscopy, and was faculty at workshops and symposia in endoscopic surgery in national and international fora. She is the faculty of CEMAST, Center of Excellence in Minimal Access Surgery Training. She has numerous papers, presentations, and publications at national and international level. She was recently felicitated by the Guinness Book of World Records for being the largest health talk, when she gave the largest health talk on breast cancer awareness. Over to Dr. Kiran Kolho.
Thank you so much. Can you hear me, Dr. Kajal?
Yeah, I can hear you.
Yes.
Okay, thank you so much for the very warm introduction, Dr. Kajal Ahuja. I'll just go to my presentation and share screen. So today I'll be talking on, can you see my screen, Kajal?
Yes.
Yeah. So today I'll be talking on 3D laparoscopy, a boon to women. The hospitals I work, Leelavati and Hinduja, where I do most of my work, and we are fully equipped with the latest 3D. Now, when laparoscopy started in the late 1970s, this is how we started, with a telescope and looking in through the telescope and with small ports. And we have moved on till there. So much advances in these past 30 years in the minimal access surgery. We all know the benefits of laparoscopic surgery: reduced postoperative pain, analgesia, reduced postoperative trauma, reduced bleeding, faster recovery, return to work, reduced wound infections, seroma and hematoma, reduced chronic wound pain, reduced incisional hernia rate, fewer adhesions and less likely to develop intestinal obstruction, better visualization for the surgeon, which is the key to good surgery, and improved prosthesis. Now, the endovision system, the laparoscopy vision, is like an electronic eye inside the abdomen. And this includes the laparoscope, telescopes, the light source, light cable, cameras, and monitoring. And a perfect image is what we want. And now with 3D laparoscopy, we actually have the 3D vision. Imagine yourself in a 3D theater, when you put on those goggles and you see that everything comes alive and everything jumps out at you. And that's exactly what we have in 3D, where we feel that we are right inside, walking inside the abdomen, and can do very good precision surgery. So a good endovision improves the quality and precision of surgery and its outcomes. We started off with single chip cameras, then 3-chip, high definition, 3D, and now the robotic platforms, which also have 3D camera systems. Now, in the 3D camera system, there's a change from, it's like opening a third eye. It's a change from the regular binocular principle. Now, the human brain combines two images into one 3D impression. So therefore, both your eyes are looking at the screen, and then you combine the two binocular visions and have a 3D impression. But 5 to 8% of humans don't have the binocular effect. Now, in a standard 2D HD monitor, the left eye and the right eye are looking into the camera. You have the console unit, the sensors, and the 2D endoscope with the object on one side. So here you have basically a 2D effect. So the depth of vision, magnification is good, but depth of vision is not as good as the 3D effect. And in the 3D effect, you have a full 3D HD monitor where the polarization glasses, it goes through the CCU. You have both the camera head has a sensor 1 and a sensor 2. So you have a dual channel endoscope, and the final vision is 3-dimensional. Now we also have this latest ICG monitor where you can see that you can put an indocyanide green dye, and all the lymphatic chains are opened up, and we can now do sentinel mapping instead of removing all the lymph nodes. Now, the advantages of 3D are the best seen in tubal recanalization. So many patients come to us after tubal ligation, they want to have another baby, and they want, and you know, with IVF being so expensive, a good tubal recanalization is excellent. And this with 3D magnification, we use very, very small needles, 3 mm, and as you can see, even the suture material is 6O and 8O. So therefore, 3D is really fantastic in these cases. Now, sometimes you have in, especially these large hydrosalpinge patients who are going in for IVF, and you have to remove these hydrosalpinges as they may cause infection. And the rates of IVF improve with excision of hydrosalpinge, which can be done with very minimally invasive techniques with high definition. Now, ectopic pregnancies, as you know, we no longer open up, even though it's a surgical emergency, a patient comes in shock. With a good 3D laparoscope, we can do a very good daycare surgery in these ectopics. This one which I'm showing you is a corneal ectopic pregnancy where there could be catastrophic bleeding. And you can see how neatly it can be done with just a little vasopressin, and then it's put in a bag and then removed. Now, this is a patient who came with a massive hemoperitoneum. Both the ovaries and tubes are all right. But we found after sucking out all the blood that she had a secondary abdominal pregnancy on the anterior And you can see that so much of bleeding, 3 liters of blood in the remove the extract and then in cases where infertility again.
But your voice has gone. Is she audible?
Dr. Kiran?
Yes.
Your sound is not audible.
Now it is audible, but like might be because you are running a video. That could be.
Maybe that's it. Is it better now? Can I?
Yes.
I'll try and.
Yeah.
Is it because of the video? I think. Yes. Is it better now? I'll speak closer to the mic.
Yeah.
So then, of course, you have the PCOD drilling in cases of infertility, vastly improve the outcomes with just a little bit of endoscopic surgery. Now, this is a patient who came as an emergency. She has torsion of the ovary, as you can see, a large ovarian cyst, and the ovary is torted because of twisting of the adnexa, more than 3 or 4, 5 twists. And these ovaries are very friable. They have gangrenous. And in the past, we had to do open surgery, but now with laparoscopy, we can just do the whole, untwist the whole adnexal mass and proceed with the. This is another patient also who had adnexal torsion. And you can see these are the patients who come into emergency. And rather than have an open surgery, just put in a laparoscope. You can see there is a large cyst with gangrene in the ovary and a twist of the adnexa. It's very friable, so you can't even lift out this adnexal mass because it is stuck to the intestines. So in situ, you can do a simple ovarian cystectomy, take out the ovarian cyst through minimal access surgery, put it in a bag, and then after that, untwist the tube and separate it from the outside adhesions. This takes not more than half an hour. The patient can go home the same day and avoid huge incisions. And precision of work, of course, is really enhanced by using a 3D laparoscope. And then, of course, all ovarian tumors are always put into a bag and then removed through the abdominal wall. Now, this is a patient who had, in the past, when we did laparoscopic hysterectomies, we always left the fallopian tubes. But now, since the past 10 years, we are removing the fallopian tubes because not only the fallopian tube leads to increased chances of ovarian cancer, but can also lead to torsion. So this patient had a torsion of the tube and ovary about 5 years after the hysterectomy was done. And of course, presented as an emergency, and these both the tubes and ovaries then quickly can be removed through a laparoscope, put in a bag, and then taken out through the abdominal wall. It's always important that no morcellation should be done without a bag. No tissue should be removed through the ports without being in a bag, because one can have spread, one can have scar endometriosis, one can have, if there is a slight, even a borderline tumor, that increases the chances. So through the umbilical port, the specimen can be removed. Now, ovarian dermoids are benign cystic teratomas, but they always have a problem because earlier, even large dermoids, we were worried about the spill, so we had to do open surgery. Now, with minimal access surgery and especially with 3D, one can very easily remove great precision, remove the dermoid from the ovary, save the ovarian tissue with minimal desiccation, and take the ovary out. Now, this is a very nice case patient who came with an acute abdomen, and she had a ruptured ovarian dermoid. You can see it's so huge, almost up to the 24-week size. The ovary and the tube are all gangrenous, and you can see the torsion of 2.5 twists over there, and this caused a rupture of the dermoid, and all the sebaceous material, which is highly acidic and chemical, was spilled into the abdominal cavity. So with a good drainage, one doesn't have to open these patients. With good drainage and through laparoscopy, this case can be handled. After de-torting,
the ovarian cyst can be removed, and you can see all you have to do is just lift up the pedicle and the whole ovary can be detorted. Very often, if you have black gangrenous looking ovaries also in young girls with torsion, one should always leave the ovary behind, because even if they look black, once the blood supply is restored to the ovary, they become well. And here you can see the untwisting and then proceed in the case. Now, another interesting thing that we do is ovarian transposition. Patients who have cancer, young patients with cancer, we want to preserve their ovaries. Ovarian tissue can be preserved, but the chances of getting a good oocyte out of that is difficult. So what we do is create a pocket in the psoas, just in the peritoneum, just below the psoas muscle, right out of the pelvic brim, and take the ovary together with its pedicle and hitch it into the psoas little tunnel over here. And so when radiation is done, the radiation is below the pelvis, and these ovaries are preserved. And later on, the patient can conceive with her own eggs, even without a uterus, with a surrogate. Now, this is a patient. Then another case where we do a lot of laparoscopic, especially with 3D, is large uterine fibroids. I have removed 3 kilos, 4 kilos, multiple fibroids, all because of the advancement in magnification and precision with HD laparoscopy. So you can see this is a large 24-week size anterior cervical fibroid, and good precision suturing, everything can be done with 3D laparoscopy. Now, this is a patient who had a 28-week size uterus. You can see that the uterus is on one side and she has a large broad ligament fibroid right up to the lateral pelvic wall, right up to the perineum. And this patient wanted to conceive. And you can see this is the lump in the abdomen, which is so huge above the umbilicus, almost up to the xiphisternum. And the primary port has to be taken almost 4 finger breadths above. So that's just below the xiphisternum, and the accessory ports which are put under vision. So this is a case I did recently, and you can see these are the port placements. And this is the inner picture. You can see there's a small uterus over there and a huge broad ligament fibroid. Now, rather than take a big incision from top to bottom up to the xiphisternum, this can be handled very beautifully through laparoscopy. And you can see we give a vasopressin to the uterus that reduces the amount of bleeding. And that's the bed where the whole thing is removed and the uterus is back sutured back into place. And these, after that, I always do morcellation of the tissue inside a bag. And these are the morcellated specimens which come out, which is almost 2 kilos in this case. This is another patient who had a huge uterus. Now, these would, we can do laparoscopically without big incisions. You can see the primary incision is right above the xiphisternum, and this is the inner picture. Now, this was a young girl who wanted to conceive, and she had this 24-week size huge fibroid. And so with the combination of vasopressin, which reduces the blood supply, one can, with minimum desiccation, take out the whole fibroid, and with 3D vision and barb sutures, one can do a very good 4-layer suture. And those are the symptoms. Now, this is another patient who was 36 weeks size uterus, and she was, everywhere she went, she was told to have a hysterectomy. Now, through laparoscope, I removed all the fibroids. There were 44 fibroids. Quickly, as you can see, these are the fibroids, and we managed to save the uterus. And later on, she went and had a successful pregnancy with IVF. This is another patient of infertility who couldn't even have intercourse because she had a large posterior cervical fibroid. This also can be tackled laparoscopically, as you can see with the vertical incision. In these cervical fibroids, there's not much musculature. So cauterization of the blood vessels is key in these cases. And this patient went on and had a successful pregnancy. Now, in total laparoscopic hysterectomy, we do large uteri like this specimen, very huge, multiple uterine fibroids, which are, this is another patient also with multiple uterine fibroids. You can see, you can hardly see the anatomy, but all these can be tackled laparoscopically with good vision and HD vision, 3D vision. And this is another patient also. You can see with large multiple fibroids. And we use a harmonic and a ligature to seal the blood vessels, and then the uterus is taken out from, here you can see there are broad ligament fibroids, cervical fibroids, posterior fibroids. So these tricky cases can all be done laparoscopically, and after doing it laparoscopically, now we'd rather do a vaginal morcellation of these large specimens. As you can see, through the vagina, giving either an apple coring technique or a lateral coring technique, under vision, the entire specimen can be taken out through the vagina, and then the vagina sutured laparoscopically. This way, there is no soiling of the peritoneal cavity, no chances of developing a sarcoma or spreading when you have cases like this, because everything is done under vision. So these are the specimens that I have removed through the vagina after doing a laparoscopic hysterectomy. Now, this is a patient who had an 8-kilo fibroid uterus. I thought I would do it laparoscopically, put it in the laparoscope, but it was too large. So sometimes one has to convert when they are like these 8-kilo fibroids, etc. Convert into an open surgery. So one should not do and die and do everything minimally access. One should always use you know your limitations and know how much you can do with the laparoscope. And of course, fluorescence imaging has now revolutionized the treatment of early cancers of the uterus as well as the cervix when we do it laparoscopically today. And we have this indocyanide green, which you can give as a dye, and then you have a non-radioactive lymph node detection, and be used in gynec oncology, and you can easily switch from the standard to the fluorescence mode by a foot switch, and all the lymph nodes come out green. We can take out that lymph node, get a biopsy done, and if that lymph node is positive, only then we go in with a full lymphadenectomy, or may have to do a para-aortic lymphadenectomy as well. So the advantages of 3D laparoscopy in gynecology are immense. In fact, nowadays, I say that I only make an incision to take out the baby, or if it's ovarian cancer. Everything else can be done through 3D laparoscopy. Like the examples are endometriosis, large chocolate cysts, adhesiolysis, deep infiltrating endometriosis. When there's endometriosis on the bowel, we can do bowel resection. We can, with circular staplers, remove all the endometriotic tissue, and these patients are free from pain and can conceive. Uterine anomalies, excision of rudimentary horn of a bicornuate uterus, unification of bicornuate uteruses can also be done laparoscopically, so that the patient who otherwise would not have conceived can conceive. Then all prolapse repairs, anterior colpos with meshplasty, posterior colpoperineography for Walsh prolapse, then laparoscopic cerclage for incompetent cervix. So many women have such short cervix that cerclage, even with cerclage, they keep having a pregnancy loss. We can do a laparoscopic cerclage for these interval cases, and even in the first trimester during pregnancy, I have done. And of course, laparoscopy for uterine and early cervical cancers. So 3D laparoscopy has really, really changed the way we operate with greater precision. It's so beneficial. It's a boon to women because they can go back to work. They go home in one day. They can walk about immediately. And when I take my rounds, I'm practicing for 40 years. I've moved from open surgery to laparoscopic surgery. And when I take my evening rounds, it's so heartening to see the patients say, did you really operate? Because with the combination of vessel sealers and harmonic, there's no tissue crushing, there's no pain. And because of the small incisions, they have no abdominal wall pain. It's such a wonder for women, and they can go back to work as soon as possible. And now we even do daycare hysterectomies and daycare myomectomies where the patient can go home soon. But of course, as in all surgery, we always must remember as surgeons, first do no harm and operate only when necessary, when indicated, and preferably with 3D laparoscopy. I thank you all for a very patient hearing. Thank you. Thank you, madam. I hope I kept my time.
Yeah. And it was very interesting with all the videos and all.
Thank you so much.
Yeah. Okay, now I'll request Honorary Secretary Dr. Pragji Vaja to please give the vote of thanks.
Good morning. Madam, am I audible?
Yes.
Yes.
Good morning. Good afternoon, everybody. I would like to thank our speakers of today's webinar, namely Dr. Sevanti Umaye, Dr. Darshana Rane, Dr. Ron Aurangabadwala, Dr. Ravi Mohanka, Dr. Jatin Kotari, Dr. Rahul Sheth, and Dr. Kiran Madam. I also thank our knowledge partners for the day, Dr. Reddy's Laboratory Limited, Intas Pharmaceutical, Sanofi Healthcare Private Limited, India Limited, HN Reliance Trust, Apollo Hospital, and La Renan Healthcare Private Limited. I thank Mr. Dipen Mehta, Mr. Aditya Kuche, and Mr. and Madam Vaishali Kanpure from DG Shield, who have given us the platform for their webinar, for this webinar, and handle all technical details at the same time. I thank Dr. Kajal Ahuja, Assistant Director, IMA CGP, Mumbai Sub-Faculty, for conducting this webinar smoothly and effectively. A big thank you to Dr. Sachin Patarkar for being MMC observer for today's session. Last but not the least, I thank you all delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much. Thank you all.
Thank you, Dr. Vaja. Thank you, everyone.
Thank you, Dr. Kajal. Excellent conduction of the program. Thank you all.
Thank you all. Bye.
Aditya?
Yes, sir. So shall I close the meeting?
Yes, yes.
Thank you.